that with the simple faith of a child, I may rely on thee.
Thank you, madam. Now our president will be delivering his welcome address.
My beloved colleagues, respected seniors, and respected speakers and chairpersons, I welcome you all for this August gathering. Today, worldwide, the death due to heart attacks, cardiology events, is the number one cause of death. 30 years before, when I was young, I was an 8 years old child. I lost my father because of this myocardial infarction. அப்போல்லாம் வந்து அதுக்கு முன்னாடி வந்து டெத்தெல்லாம் நடக்குதான், ஏன் நடக்குதுன்னே தெரியாது. நல்லா தான் இருந்தார், நல்லா சாப்பிட்டு படுத்தாங்க, செத்துட்டாங்கன்னுவாங்க. நல்லா வந்தாங்க, வீட்டுக்குள்ளே வந்தாங்க, விழுந்து செத்துட்டாங்கன்னு சொல்லுவாங்க. ஏன் என்ன காரணம் அப்படின்றதே கண்டுபிடிக்க முடியாது. பிகாஸ் ஒன்று வந்து அவேர்னஸ் இன் தோஸ் டேஸ் இட் வாஸ் வெரி லெஸ். அந்த சிபிஆர் அப்படின்ற ஒரு விஷயமே அப்போது ஒன்றும் கிடையாது. ஈவன் ஸ்மால் டவுன்ஸ் அண்ட் வில்லேஜஸ் ஸ்மால் டவுன்ஸில் கார்டியாலஜிஸ்டே கிடையாது. ஒரு டிஸ்ட்ரிக்ட் வந்து ஒரு கார்டியாலஜிஸ்ட் 2 கார்டியாலஜிஸ்ட் தான் இருப்பார். ஒரு இசிஜிக்கு ஆக்சஸே வந்து ஒரு டவுனில் ஒரு இசிஜி சென்டர் தான் இருக்கும். மேபி ஒரு ஹாஸ்பிட்டல் இருக்கும், ஒரு இசிஜி சென்டர் இருக்கும். கவர்மெண்ட் ஹாஸ்பிட்டல்ஸில் ஒன்று இருக்கும், அவ்வளோதான். So when I was an 8 years old child, my father entered and suddenly he died, collapsed in front of us. 1 year we made him to lie down. எனக்கு தான் நல்லா ஞாபகம் இருக்குது. நல்லா அவர் காலை தேய்ச்சி விட்றாங்க, அவருக்கு தண்ணி கொடுக்குறாங்க, எது பண்ணக்கூடாதோ அதெல்லாம் பண்ணிகிட்டு இருக்காங்க. We are waiting for the doctor to arrive. The doctor கால் பண்ணி வந்து ஒரு 1 hour கழிச்சு he declared dead and that was the thing. So in those days it was like that. என்ன காரணம் தெரியாமல் டெத் ஆன சிச்சுவேஷன் மாறி then came this thrombolytics and heparins. அது வந்து ஐசியூ கேர்னு ஒரு கான்செப்ட் வந்து கடந்த 20-22 வருஷமாக வந்து இந்த ஐசியூ கேர் அப்படிங்கிறது ஒரு டெவலப் ஆகி ஈவன் ஸ்மால் அண்ட் மிட் சைஸ் ஹாஸ்பிட்டல்ஸ் தே ஹேட் அன் ஐசியூ. They were able to do a first initial treatment effectively, and things have evolved down the line. Now it is in a situation that even ஒரு எம்ஐன்னு வந்துட்டதுன்னா the CPR develop ஆயிருக்கு, the IMI can be identified within few hours and patient can be directly taken to cath lab and the clot can be blasted. So things have developed this much extent and we are lucky enough to give life to our patients. ஸோ அதோட ஒட்டி தான் வந்து இப்போது இன்றைக்கி வந்து our topic is going to be all MI related cardiac coronary artery related event talks. So let us wait what the experts are going to say. I wish this CME program to be a great success. Thank you.
Thank you, sir. With this, we will be moving on with the academic session. I request the chairperson for session 1 to come over to the dais. I'm happy to invite எல்லாம் அலர்ட்டா இருக்காங்க. I'm happy to invite the chairpersons of session 1, Dr. Moorthy, senior consultant cardiologist at NN Hospital, visiting consultant at Apollo Hospitals. Dr. A.K. Gautham, senior consultant physician at Hindu Mission Hospital, and Dr. Dhanraj, consultant cardiologist. Thank you very much, sirs. Now I hand over the mic to our AMS chairman, Dr. Venkatesh, to introduce the speakers.
Good afternoon. So indulge me for 5 minutes. I would like to say a few words before actually introduce our speakers for the day. Dr. Saravakumar was saying about the non-availability of care a few years back, probably a decade ago. But I want to say, what was the idea? Why did we think about these topics for discussion today? So one of the reasons is, let me start with this. 20 years ago, my professor of cardiology, both his daughters were getting married to 2 nephrologists. So nephrology 20 years ago was not a specialty which did not have many interventions. So it was a very surprising decision. So we all asked him, why is it, sir, that your daughters are being married to nephrologists, which is not a very well-known specialty? He said, because of better coronary and cardiovascular interventions, people are going to live longer and longer. They are going to live long enough to develop kidney disease. So the future belongs to nephrology because of the better work done by cardiology. So the mortality rates have visibly come down, and one of the raging topics which still continues to raise a lot of controversies are what you are going to do in as a primary prevention, what you are going to do in the setting of secondary prevention as a physician. Then comes the role of other device-based interventions and whatever modern interventions, etc. So we thought we should settle down some of these questions. So I request all our members, esteemed members, to think about this. Whatever questions that you want to ask about it, I think we'll put it across to the panelists directly. So with that, I welcome Dr. Varun. And you all are familiar with Dr. Varun. He is the superstar of Hony Hospital, if you all don't know that. Because of the tremendous amount of work that he has done, we have learned a lot from him. His ability to grasp multidisciplinary problems is very unique, and that is the key point. And therefore, without much ado, I would ask Varun to go through his talk.
Thank you, sir. Thanks IMA and thanks Dr. Venkatesh for giving me this opportunity to speak on the primary and secondary prevention of coronary artery disease. As sir rightly said, it'll take a few more minutes till the laptop is on. As sir rightly said, getting a coronary artery disease, intervening, treating it, and then maintaining post-intervention is correct, which is very widely available these days. But as a physician, as a primary care person, preventing people with risk factors or identifying the risk factors and preventing them in landing in a coronary event gives them a more longevity and better quality of life, and the terminal event can be handled later, but we are pushing off the terminal event, increases the quality of life for the patient and increases the longevity of the patient. As primary care physicians in our office practice, rightly identifying a risk factor, let it be a primary cause, modifiable, non-modifiable, intervening pharmacologically or non-pharmacologically, spending time with the patient in changing the risk behaviors will decrease the incidence of coronary artery disease. As primary care physicians, we are more interested in reducing the incidence and the disease burden in the society. So my topic is primary and secondary prevention. What is the difference? Prevention. We are going to prevent coronary artery disease, or in short, we are going to prevent a terminal event or a significant life-threatening event happening to a patient through two interventions, which is primary and secondary. What is primary? A patient who has not developed any coronary artery disease so far. 40, 45-year-old, probably a newly diagnosed hypertensive, diabetic, do a treadmill, normal, even do an angio normal. So no coronary artery disease, only modifiable risk factors. These people, whatever you intervene in your office practice is primary prevention. People with established coronary artery disease, those who had an acute coronary syndrome or a stable angina and established coronary artery disease, preventing them from worsening of their coronary artery disease and landing up in a life-threatening event in your office practice is secondary prevention. Both roles are very significant roles for a physician. Even after diagnosing a coronary artery disease, still our diabetes and hypertension and your dyslipidemia and your modifiable risk factors like smoking and alcohol lies with the primary physician. Every patient, please believe me, will listen to your family physician and a primary physician and speak more freely than to a specialist. So it is our duty to change their risk factors even after developing a coronary artery disease. So when is this? So, thank you. So, when did this risk factors as a cause or identification of risk factors become very evident? 1961, when the first time Framingham Heart Study, most common, everyone knows the Framingham score and the Framingham Heart Study. It was as early as 1960s when physicians decided that we should develop a scoring system to assess the risk for any patient and stratify them as low, moderate and high risk and do appropriate interventions based on the risk score so that reducing the end cardiovascular events. There are 4 categories of risk factors which I'm grossly going to discuss in future and going to intervene on each and every risk factor on how to going to intervene both pharmacologically and non-pharmacologically. Predisposing factors are factors which is not in your hand. Age, gender, family history, genetic history. Nama kaila kadayadu. What we inherit. Risk modifying behaviors like smoking, bad atherogenic diet, alcohol intake, poor physical activity, sedentary lifestyle. Metabolic risk factors, acquired dyslipidemia, hypertension, obesity, diabetes, combined together a metabolic syndrome. We have multiple disease markers these days. This is also part of risk stratification and risk assessment, which I'm going to cover in my future slides, like the calcium score in a non-symptomatic patient and ECG changes of LVH suggestive of hypertension uncontrolled, stress disease results, and other history of vascular disease. So major traditional risk factors: age, which will not be able to change, male gender, more predominant, female postmenopausal, dyslipidemia, high LDL and low HDL, diabetes, hypertension, smoking, and a family history. Emerging risk factors, what we are seeing these days is the metabolic syndrome. 1 in 20 or 1 in 25 patients in our clinic, on a regular clinic, will be a metabolic syndrome. Obesity in the anvil, even adolescent and young 20s to 30s having obesity with metabolic syndrome, diabetes, hypertension is very common. High triglycerides, now newer markers of lipoprotein A, fibrinogen, homocysteine, urine protein creatinine ratio. Microalbumin is an early marker of an end organ damage. When you have one vasculopath component causing the kidney, that means you're having another vascular complication in any other organ, most common your heart also. High CRP, a component of a high inflammatory marker, is an indirect markers of saying that you're having a chronic inflammatory state, increasing your atherogenicity, may lead to a cardiac or a stroke or any other vascular event in future. These are early markers which we can see objectively and do some intervention, and same objectively see whether these inflammatory markers are coming down to see the outcome of reduced cardiovascular outcomes in future. Most common, males less than 55, females less than 65, hyperlipidemia. You could see the list these days. Earlier we used to think diabetes. Earlier it was like diabetes equal to coronary artery disease, then became hypertension equal to coronary artery disease, now cholesterol equal to. Most of our clinics in our general practice, we don't heed much importance to dyslipidemia as we heed to diabetes and hypertension. But first on the list is dyslipidemia these days. Then equivalent importance to your diabetes and our hypertension. Metabolic syndrome, chronic other inflammatory states like chronic kidney disease, and other inflammatory states like SLEs, lupus, any chronic illness requiring long-term medications. In females, history of pregnancy associated conditions that is increased like preeclampsia or more predisposed for cardiovascular condition. These are screening criteria. When you ask on a regular history to your patients in your outpatient clinic, a 35-year-old female comes, she comes for a regular checkup, says she's got hypertension and we are just treating her hypertension. On a history, she says, sir, during my first pregnancy, I was pre-eclamptic, I had eclampsia and other things. Her risk from a normal person at the same age having hypertension, well controlled, is more to develop a coronary vascular disease than another population. So these factors will help us in risk stratifying our patients. Lipids, biomarkers, persistently elevated triglycerides. This is a little change with the current guidelines because currently we are not going with 175 triglycerides, it's around 450. HSCRP, elevated lipoprotein A and elevated apoprotein B of 130. So this is one simple scoring system which I would like to establish today. A Framingham risk score, very simple score, we can keep it in our table. Calculators are available on everybody's mobile, patients can also do. A simple scoring system based on age, our LDL, our HDL, total cholesterol, office measured systolic blood pressures, and questionnaire like diabetes plus or minus and smoking. This gives us on a 10-year cardiovascular risk, we can predict the one patient coming and asking, sir, right now I'm diagnosed with diabetes. I'm 30 years old. My father died of heart attack at 55. Sir, I'm scared. What is the chance that I will develop a heart attack? We are most of the time, we're like, possible, if you keep this under control, you will be good. You may land up, you may not land up. we can give specific answer based on the risk. Your 10-year risk for you, if your control is like this, you will reach up less than 10%, 20 to 40%, more than 40%. So you're a low risk, moderate risk, or a high risk, which would make the patient more educated. When we give him non-pharmacological interventions, it will make him more compliant to follow us properly. So these risk factors, based on this, we have a scoring, and less than 20% or less than 15% is a low risk. 15 to 20 and above is moderate risk, and above 40% are high risk individuals. In simple, for us to understand, 2 or more comorbidities with smoking increases your cardiovascular risk by more than 50%. 2 comorbidities without smoking, around 30 to 40%. 1 single morbidity, well controlled, even well controlled, your cardiovascular risk will be 30% or 20 to 30% in a 10-year scale. So what is the interventions, primary interventions we'll plan for our patients? I'm not starting with hypertension and diabetes, I'm starting with smoking. Most common, very subdued and not understood by many people, but many a times we don't even ask the history, do you smoke? Unless and until the patient comes with a respiratory symptom. Many of them are non-declared, sir. Oru rendu cigarette dhaan pudicha, adala smoking la kanaka sir. Adala illa sir, I'm not a smoker. Smoking history makes proper history, and smoking is one major risk factor for landing up in a coronary vascular disease. So it depends, the risk increases with the number of cigarettes and the number of years you have smoked, and obviously with more age. Smoking doubles the incidence of coronary artery disease and increases the coronary artery disease mortality by 50%. Very rapidly moving in our country because of the change in the attitude of the younger generation and the cultural change what we are seeing. The differences with many patients will say, I smoke this, I smoke vape, I smoke this, but no difference, regular filter, whatever it is, smoking is smoking, tobacco is tobacco, tar is tar. It increases your coronary vascular disease. So unlike other modifiable risk factor, cigarette smoking is one risk factor. Diabetes you can control, hypertension you can control. Smoking is one thing you can stop. This, if we encourage to our patients on every repeated office visits, either pharmacologically or through counseling, and if the patient quits, from the time of he quitting, he comes to a non-smoker level within 2 years. And the coronary vascular disease, the lung component even reverses within 5 to 6 years completely. So whatever years you have smoked, you can reverse the entire component the moment you can stop smoking, and this we should tell the patients the outcome of it and encourage them to stop smoking. Recommendation, this is AHA guidelines of treatment for tobacco use. All adults should be assessed at every healthcare visit for tobacco use and tobacco use status. Tobacco abstinence to be requested or firmly advised to quit. These are level A evidences. And all adults who use tobacco abstinence is reduced the cardiovascular disease significantly. Either behavioral or pharmacological therapy can be used. Problem solving skills, social support outside treatment, routine non-pharmacological therapies, pharmacological therapies with bupropion and replacement of nicotine. Either we use a patch, significant smoking, say one fellow smokes about a pack, say 10 cigarettes, start with about 7 milligram. 20 packs start with about 14 milligram replacement. You can keep increasing based on what the requirement of the patient is. Chewing gums are also available, which can be used at regular frequency. 2 or 3 cigarettes he smokes at one time, he can take 1-2 milligram, another 2 or 3 at the next time. And lozenges are also available of the same thing. This is just nicotine replacement. So reduces your chances of tar-induced and other component of the cigarettes induced coronary vascular disease. These can not be initiated, necessarily be done by a psychiatrist. As general practitioners, we can easily recommend to all our patients, because we tell for smoking de-addiction, you want pharmacological replacement, go see a psychiatrist, none of them will go. As general physicians, we have the obligations to take care of our patients. We can treat their basic problems. So these are small replacements which does not need a psychiatric prescription, and we can give them. Bupropion obviously needs a psychiatric prescription, and varenicline. The next component apart from smoking is hypertension. Again, to state, I am bringing hypertension before diabetes. The reason today's main killer is hypertension, because still largely unidentified. Couple of months back, we had a similar talk over here. How much of masked or unmasked hypertension we have in our community at an younger age group, which is becoming a major killer for our coronary artery disease. High potential risk factor for CVD. It has got a graded level. Every 10 mm rise increases your systolic blood pressure and your diastolic blood pressure, increases your risk of your coronary vascular disease proportionately. It is a linear curve. Your blood pressure goes up, your coronary risk goes up linearly. There is no other change. It's same equal. An increment of 20 mm of systolic blood pressure or a 10 mm of diastolic blood pressure doubles your risk of coronary vascular disease. An office pressure of say 150, 160, patient says at home I have had 140. These are patients, in the previous couple of months back we had a talk to go for ambulatory BP monitoring or home BP monitoring on a regular basis and make the patient make a log of what they do in there, record their BPs at home and bring it, whatever standard deviation in your home BP apparatus monitoring is. Because the 10 to 20 mm targets 140, 145 parallel reach a target of 135 by 85 in your regular pharmacological therapy and reduce the risk of BP, because even 145 or 150 patient asymptomatic stays on for a long time, increases his coronary vascular disease by almost doubles, 50% increase. You will end up on an heart attack rather after 10 years, you will end up on an heart attack in 5 years itself. That small 10 mm rise. So that is very important for us to watch with continuous monitoring of BP, either home BP monitoring and along with our office BP monitoring. Multiple trials have showed intervening in controlling of hypertension alone reduces significant coronary vascular disease. These are the threshold recommended by AHA. Just to come down on this slide, very significant, very small thing. Estimated 10-year risk is around 10% to 20% if your blood pressure is around 130 to 140 and 80 to 90 in your diastolics. Increase from 140 to 150, that is your stage 1 hypertension, your risk factor increases by another 20%. Stage 2, it increases by another 20%. So in stage 1 and pre-hypertension, we still prefer patients having 130 or 135 blood pressure, start initiating non-pharmacological therapy. Tell them salt restrictions, tell them regular walking, tell them 8 hours of sleep. Don't say that 135 by 80 your blood pressures are normal, you don't have hypertension. That is true, but you are still predisposed to develop an hypertension and increase coronary vascular risk. Initiate non-pharmacological interventions at that stage itself. That is just advocating healthy lifestyle. And after that, pharmacological therapy, as we know, but regular treatment of hypertension. The main non-pharmacological components of treating hypertension would be weight loss and healthy diet, the DASH diet, fruits, less oil, low salt, 5 grams of salt, less sodium intake, and physical activity, a simple physical activity which I'll cover in the future sides of obesity also. A simple activity of 150 minutes exercise per week, moderate intensity, a brisk walk of say 2.5 kilometers for 30 minutes a day, as simple as that. High intensity work of any significant gym work or anything, 75 minutes of high intensity. But there are many trials of comparing these two also. But the outcome is better with a moderate intensity, sustained physical activity of 150 hours per week rather than 75 hours intense activity. It reduces your cardiovascular mortality better. So this can be done either by walking, whichever way you want. Alcohol consumption, this is actually a wrong slide. This is for the Western data. For Indian data, alcohol, even 1 drop of alcohol increases our cardiovascular risk. There are many Western Mediterranean data which says alcohol at moderate consumption reduces cardiovascular risk, but no Indian data, so not for our population. So alcohol is no for us. First line of treatment for hypertension, diuretics, beta blockers is choice of drug with calcium channel blockers to start with without any end organ damage. If you have coronary artery disease, then it becomes a secondary prevention to reduce your hypertension. The choice of first drug should be a beta blocker and an ACE-ARB than a calcium channel blocker. With renal involvement, the ARBs are much better, and with any other vascular component, the ACE-ARB is much better. So the choice would be no other organ involvement, significant calcium channel blocker, then your ACE-ARBs. If associated with the coronary artery disease or any other vascular component, a beta blocker with ACE-ARB. Renal component involvement, significantly start with ACE-ARBs. Diuretics, add on. Dyslipidemia, the most common thing. My next speaker is going to elaborate much detailed on the newer drugs and the availability and the treatment choices now which is modified for lipidemia. Earlier, like, there were always a controversy, should we use statins? Statins is good, statins is bad. Statins is going to help, statins on the long run, pharma driven, it is not helping, causing lot of problems. Single verdict, yes. In secondary prevention, statin has got a significant role. In primary prevention, yes, with other risk factors involvement. So it's a straight verdict. Multiple trials have gone on, there is no doubt on it. So LDL directly related to your coronary vascular disease. Target of 100 if you have less than 100, ideally less than 70 if you have other comorbids like diabetes and hypertension and smoking and alcohol. An increased HDL is inversely related to your coronary vascular disease. The newer component of VLDL cholesterol and the low HDL, a single best predictor of your CVD is total cholesterol and HDL ratio. Ideal ratio less than 3, an intermediate risk of 3 to 5, and a high risk greater than 5. Apart from this, a single predictor I would still say is an LDL. LDL goal of less than 70 would reduce either if you are able to reach it non-pharmacologically, if not, do it with statin. Is there anything that we should reduce statins after 70? I think my next speaker will speak, but the goal is lowest or the least is the best. And there is no change. Give as much as statins as possible to reach the least. There is no need to drop your statins unless and until you have significant side effects secondary to statins. You reach the least if you have a coronary artery disease. So this is a straight Framingham study and a multiple risk factor intervention trial showing a linear graph of relationship with your cholesterol and an associated coronary vascular disease. Every 1% increase in total cholesterol is associated with a 2% increase in a coronary vascular disease. I think I'll just, one single thing, the red which I've highlighted, the lower is the better. So the least of LDL is the better. There is no lower limit of LDL below which we stop statins or reduce statins. Even 10 milligram of LDL, continue statins. The least is better when you have a coronary artery disease. That is part of the secondary prevention. I think the rest of the goals my next speaker will be speaking. I'll skip that. Simple, low risk, 5%, 5 to 7.5 borderline percent, and the intermediate 7.5 to 20%. Based on the risk involvement, this is for a risk stratification based on your LDL levels. If you're having borderline or intermediate risk and an LDL goal of about 100 and above, initiate statin therapy in patients even if they do not have any coronary artery disease. So a recommendation in adults with an intermediate risk of 7.5 to 20% of a 10-year risk of your in a Framingham study, statin therapy reduces the risk, and the decision is made after statin therapy or moderate intensity statin should be recommended. There is no doubt about it. The same thing, recommendations with grades A and B. Even at ages of 20, they say start screening. The current guidelines is start screening from 20 years. Not necessary you start screening at 35, 40 years. Family history or not history, start screening every year for dyslipidemia at 20 years itself. Patients, this is one slide which I wanted to put on the calcium score. This is a selected candidates who will see a CAC measurement who benefit from knowing their calcium score, because based on this calcium score, patient is completely asymptomatic, does not have any other thing. They want to know whether this taking the statin is going to really help me or not. So we have other ways apart from our HSCRP and other things to look at our inflammatory markers, and apart from our lipid profile, this calcium score which we do on a CT angio, look at this calcium score. Patients who are very reluctant to initiate, you can show this. You can find if the calcium score is more. Calcium score is more than 1%. Calcium score is 0, no choice of statins, not necessary. Patient is fine. Even a calcium score of 1 to 99, initiating of a statin would benefit in reducing the coronary vascular disease. Obesity, the next risk factor which has to be addressed very commonly. Always measure BMI, ask your staff who puts your weight and height, ask them to put a BMI. Next, simple calculation, we forget to do, we'll be very busy in our practice, we don't calculate BMI, only by our look we say, you have a higher BMI, you may be obese. There are many lead individuals who are still having high BMI. So the BMI is a very significant number, very simple calculation, we can make our office staff do it. Any BMI above 30 needs intervention. Any BMI above 30, you need to talk to them to reduce weight, either non-pharmacologically. If they are unable to reach that, initiate pharmacological therapy, and if necessary, refer to an endocrinologist. So obesity has also got a linear relationship based on the age also. Overweight, including obese, as the age progresses, the increase in coronary vascular disease goes up. As the age is low, there is a decrease, but the point is your component, the understanding was much different in previous years, that is in the 1990s era, when we didn't have direct access of assessment of this as a risk factor. But as we started looking into it, the change in this change is only because we started assessing obesity as a risk factor. Now we understand obesity increases, the coronary vascular disease chances also increases, so we should intervene. What are the factors of intervention? Class 2 intervention, dietary counseling, 1500 to 1800 kilocalories per day. Behavioral modification, increase physical activity, as I told, 150 weeks physical activity per week, psychosocial support. Pharmacological therapy, yes, orlistat and other therapies, and if morbidly obese, you can give them an option of an endocrine surgery, bariatric surgery. Grade A evidence for reducing the body mass index, and body mass index has a direct relationship for coronary vascular disease. Just for a small slide on the 75% of urban Indian don't meet, there was a survey which was done, and only urban Indian population, but predominantly in North India, didn't cover all parts of India. It was thought that yes, I do gym activity and I do all these things, but based on their consistency, there was a survey and 75% did not meet the actual AHA recommendation. So simple brisk walking, mortality reduction benefits are more, reduced risk of stroke, new onset of diabetes is also reduced, secondary prevention reduces the mortality by around 25%, recommendation minimum 30 to 60 minutes of moderate activity most days of the week, generally we say 5 days per week minimum. These are recommendation levels, most of them are grade B level recommendation, as I said 150 minutes per week, or a high intensity is 75 minutes per week. Diabetes, the main killer, 90% of diabetes, 1/3 of people with diabetes are unaware of its presence, so diagnosing diabetes in our office practice is a primary goal in preventing cardiovascular disease. Patient with family history, patient with significant body mass index changes, as for all their basic component of history, even if they come for any other complaint, nocturia, cyclic weight loss, general tiredness, always screen for diabetes. Very powerful risk factor. It causes 69% of the deaths. See, diabetic patients, 69% of coronary vascular disease, 7 to 8-fold increase if diabetes poorly controlled. Direct linear relationship, whether men or women. Men obviously more increased risk with diabetes to have a coronary vascular disease. So the number of risk factors like only blood pressure with cholesterol and low HDL, blood pressure, cholesterol, low HDL with diabetes, blood pressure, cholesterol, low HDL, diabetes and smoking. Each and every factor is a gradation increase. So add on of each factor increases your risk factor from 10%, and if you see add on the 5 factors, your chances of getting a heart attack are more than 60% than a normal population. So recommendations, all type 2 diabetes should be treated to a goal target of 6.5 HbA1c. Either non-pharmacologically, pharmacologically from the cardiac point of view, choice of drugs with metformin for both obesity, SGLT2 inhibitors and GLP-1 analogs. Not delving much into the treatment of diabetes, which is a long component. So direct risk enhancers in diabetic patient, long duration, 10 years of diabetes even when controlled, the duration of diabetes in itself is a risk factor for coronary vascular disease. More than 20%, more than 20 years, you have a high risk, you have more than 20% chances than another normal population. Significant albuminuria, which is suggestive of an end organ damage, increases your coronary vascular disease. Retinopathy, neuropathy, obviously, again point of an end organ damage, again says you are a vasculopath and increase in coronary vascular disease. Your ankle brachial index, which we forget in our clinical practice these days. Not everybody sees the fundus, not everybody does the neuropathy test, not everybody is able to look at albuminuria each time your patient comes. A simple ABI, which we can do in our clinic. ABI less than 0.9 in our smokers and diabetics, suggestive of a vascular disease. Peripheral and all peripheral vascular disease patient will have coronary vascular disease. Straightforward dictum. So very simple index, you can say the patient is at risk factor for a coronary vascular disease, then do further evaluation for coronary vascular disease, either with a TMT or send him to a cardiologist. Just keeping. secondary prevention. So what I've covered so far is primary prevention and few other things, secondary prevention with the coronary artery disease also. That is treatment of diabetes, hypertension, and antiplatelet agents. Antiplatelet agents, do we use primary prevention or secondary prevention? Big debate. Many people on our general practice, diabetic patient, hypertensive patient, non-documented coronary artery disease. Patient is having coronary artery disease or not, we do not know, but he is a diabetic hypertensive. Just for prevention, I am giving you a low dose aspirin. Is that concept right or wrong? Not really. Earlier 20 years back, yes, but right now, no. There is no significant data suggesting a prophylactic aspirin as a primary preventive role for reducing coronary vascular disease. Patient with coronary vascular disease, coronary artery disease is definitely requiring an antiplatelet. These patients, antiplatelets, dual antiplatelets if they have an ACS or a single antiplatelet based on the lesions, definitely as a secondary prevention is recommended. 5 large primary prevention trials with low dose aspirin was done. Very small benefit, not significant p value, less than 6% was shown in a meta-analysis for men. In women, they are still studying, a large trial still going on. And the breakpoint is that 10-year risk by reduction of a coronary vascular disease by giving up aspirin for men is less than 6%, not significant enough. So the general AHA guidelines is as a preventive, primary prevention should we give aspirin, not necessary, but you can take it on a case-on-case basis. Based on the other family history, you feel this patient can be a vasculopath, you can add upon him aspirin. Beta blockers, yes, as first choice of therapy or second choice of therapy, you have an ACS. Multiple beta blockers are available. The best choice of beta blockers currently with bisoprolol and carvedilol has got, after the common trial, much benefit, cardiac mortality benefit better than the other beta blockers. ACRBs always our charm. ACRBs not only remodels our heart, reduces our blood pressure, keeps our kidney well. One of the wonder drug for all the specialties. Try initiating ACRBs at the earliest. Keep a watch on your potassium. Keep a watch on your creatinine. Don't be scared about it. But please do initiate. That helps in all organ saving thing. Anticoagulants as primary prevention, definitely no. Multiple trials have gone by. Is there any role patient, if I put him on an anticoagulant, oral anticoagulant, is it going to reduce the patient developing coronary vascular disease? Definitely no. So there is no role for anticoagulants as primary or secondary prevention at this point. Aspirin use, as I mentioned, and this is another component, postmenopausal women who are at more risk to develop a coronary vascular disease than a premenopausal woman in compared to a male population. The hormone, why we say because of the hormonal loss and hormone replacement therapy, does it reduce your coronary vascular disease? Definite no. Hormone replacement therapy did not prove, the HERS trial did not prove any benefit in reducing a coronary vascular disease. So hormone therapy is no longer recommended to reduce CVD, and no patient unless and until other gynecological issues are there should be recommended a hormone replacement therapy in a postmenopausal woman. Dietary factors, the DASH diet. Just come to the last point of primary and secondary prevention. Key takeaways, all patients above 40 should be screened using a Framingham risk score system for coronary artery disease in our practice. Screen for tobacco usage and initiate cessation of tobacco usage during your every office visit, either pharmacologically or non-pharmacologically. Target goal of blood pressure 135/85 for all your patients, hypertension screening, diabetes screening and goal targeted therapy using metformin, SGLT2 inhibitors. Dyslipidemia screening and statin usage as discussed earlier in the most beneficial population, and aspirin being less efficient as a primary prevention. I'd like to end here. Thank you. Any questions?
Panelists can go ahead and please.
A nice presentation, Ron. You discussed the risk factors for CAD or MI nicely. But there are some situations where there is no risk factor. No risk factor. Not a smoker, not an alcoholic, no diabetes, no hypertension, still they develop MI. Is it possible? Yes, it is called MINOCA, myocardial infarction of non-obstructive coronary artery. It means without a block. What is our common faith? Arun discussed about so many risk factors. Yes, it's true for the development, for the growth, build-up of atheromatous plaque. But to produce MI, you need not have a block at all. 10% of MIs are presenting like this. You may ask, what is the cause? Without any risk factors. Yes, as madam says, stress. What stress? Physical or mental? Both. Coronary dissection. If somebody is not able to lift a 50 kilogram of a table, if he tries to do that, he may develop a spontaneous coronary dissection. Scared. So that will promote a MI. And there are some situations where coronary artery spasm is possible. Either drug, cocaine, or this ganjas. If they smoke, youngsters, they develop a coronary artery spasm. Some drugs also can produce a coronary artery spasm. Chemotherapy, some drugs can produce spasm. So these people, they may not have a block at all. Still they develop MI. Sometimes coronary artery embolisms can produce this problem. Physical stress can produce Takayasu disease that can also present as a MI. So 10% of people with MI need not have a critical or stenotic block. If somebody undergoes an angiogram, it shows 30%, you should not be happy. To produce MI, you need not have 99% of block, you need not 100% block. 20%, 10% can produce a MI. How? When the endothelium covering the block get eroded or ruptured for many reasons, like smoking, physical stress, excessive catecholamine secretions, for various reasons, the endothelial layer can get disrupted, initiating the cascade of thrombosis. The outcome depends upon the fight between plasmin and thrombin. If thrombin is successful, he will end up with MI. If plasmin is successful, he can have a spontaneous thrombolysis. So we have seen many times patients have chest pain, ECG evidence of MI-ST elevation. When we see in our clinic, they are settled, it will be settled by this time. It means the plasmin has won over the thrombin. The endogenous plasmin can dissolve the clot initiated by the plaque rupture or plaque erosion. So this is one important thing. And regarding the women especially, those days it was a faith that women are immune from coronary disease. It is not so. Even the pregnancy age of women can develop a coronary artery event. Don't get afraid of it. I'm not threatening you, but telling that. Especially during pregnancy, very important point. During pregnancy, because of the hormonal influences, your coronary vascular media will become softened. Endothelium will be softened. It is prone for dissection. When you subject the patient for normal delivery or due to various stress during labor, can develop a dissection, left main coronary dissection. It can propagate to LAD or other branches, resulting in MI. The symptom will be back pain. Please understand. A woman, myocardial infarction, the symptoms, you cannot have jaw pain, reduced shoulder, no. Severe back pain. Post-delivery, postnatal, severe back pain, don't think it is a prolonged lying on the cot. Kindly take an ECG, rule out MI. This is the thing I want to highlight. And the many people say, sir, I am a pure vegetarian. Is it chance of plaque development? Many people vegetarian say, I am pure vegetarian. So their doubt is genuine. Cholesterol, plant, there is no plant source of cholesterol. Cholesterols are mainly from animal source. But however, in vegetarian people, there is endogenous production of cholesterol happening within the liver also. So that can trigger the problems. So these are points I want to highlight it.
One more small thing that I wanted to point out. One, it was a very good presentation. Primary prevention is something I think we really should stress. Actually, this begins in the schools and colleges.
True, sir.
If we as a medical community target that group in the school and colleges, where we talk to the school authorities and the college people, that your children must have a games period almost every day.
Correct.
And see to it that they are eating proper homemade food, avoid the junk food. If that education begins there, in the long run, definitely they are going to be healthy.
Correct. True, sir.
So that school education, where this is part of their training, You know, that why this primary prevention is being attempted, why doctors are telling you to do all that, that will be very helpful.
True.
I think that's a very long thing. You know, எத்தனை ஸ்கூல்ல playground இருக்கு? They all have, you know, accreditation. Many schools don't have playgrounds, and many colonies don't have any playgrounds for children. எங்கள் காலத்து மாதிரிலாம் எங்கே போனாலும் ஒரு மைதானம் இருந்தது, ஃபுட்பால் ஆடணும், பாஸ்கெட்பால் ஆடணும். No, children don't play at all, பாவம். They don't play at all. And most of the time they are eating junk food.
True.
No one gets homemade food. Swiggy, Zomato, எல்லாம் இருக்குது. So if we can target the primary prevention, we will have a healthier generation. Whether other risk factors come later or not, that's a different thing. But then that primary prevention, I think, will go a long way in preventing it.
Another very important. So that's what I want to tell, important point. So people are stressing on exercise, exercise, exercise. Okay. What is good exercise for the cardiovascular system is isotonic or dynamic exercise. What does it mean, isotonic? Any exercise should involve the movement of the body. Body should move. That is isometric, it's a static exercise, should be avoided. Especially patients with hypertension should not do. Recently, every month we see gym master died on the spot. Gym master died on the spot. There is another classic example. Punit Reddy during treadmill he died. Saurav Ganguly developed coronary event while doing treadmill test. So, isotonic exercise. People may ask you, practitioners, please tell them, you do the exercise which involves the movement of the body. They will ask, what exercise? Walking, jogging, swimming, only 3. Don't allow them to do a static exercise. What is static exercise? Gym. Gym is a culprit. It's only for bodybuilder. Body gym, not for healthy living. That's important point. Second thing is, as I said, very important point. The atherosclerosis starts in the younger age. Fatty streaks deposition happens in the intimal layer, basement of the intimal layer. The progression of the fatty streak to the development of plaque depends upon the lifestyle, especially the food. Especially the food, lifestyle, food, very important thing. So we should encourage the food. Food like today's biryani is not good, but it is nice. It's nice. So how to control? Control the mouth. Thank you, sir.
Thank you, sir.
I think, are there any questions from the audience? We'll take one question from the audience.
What is the difference between physical activity and physical stress? How do you demarcate? What is your BMI?
If I am lifting that back, sir will be very conscious about the timing. The timing is very timing. So physical stress, you said no. Lifting a tractor's back wheel is a physical stress. A person who's not able to, if Dhanush does lifting a tractor, back wheel tractor is a stress. I cannot shift the table of 100 kg. That is physical stress. What is the other question you asked, sir? Huh? Physical activity. That's I told you, no. Any exercise, like you should go marathon, walking. Body should move from one place to another place. No weightlifting. No squatting.
What about treadmill in the gym?
Moderate speed, intensity speed. We can do that. And inclination should be controlled inclination. Many people think faster the rate, good for the heart. Very bad. Bad faith. Should not do faster. Slow intensity. And inclination should not be very high. Because when people think high inclination, very energy will be burnt out. No. You can develop early knee joint problems.
No, as an example, one more question. What is your preventive methods?
I am very bad patient.
Yes, sir.
Thank you, sir. Sir,
Yes,
I
sir.
have a very small doubt, and you need to help me with that, Varun, sir. So, whenever I am writing history of smoking in my case sheet, I am ending up in trouble. Number one, the patient is not coming to me again to my OPD. Okay. Number two, regarding the insurance. So, some of them would have declared that they're an active smoker in the insurance, or some of them would not have. So, finally, when it comes to the bill, the insurance people are again, I'm having trouble with them as well. Do you have any suggestions?
Generally, I don't document, sir. Because I remember my patient, I know he's a smoker, I'll tell him cigarette பிடிக்காத உனக்கு தான் கெடுதல், நீ பிடிச்சதை இப்போ சொன்னா இதுக்கும் காசு கட்ட மாட்டான், உனக்கு ஹெல்ப் பண்ணுறேன், இப்போ காட்டிட்டேன்னா இதுக்கப்புறம் கிடைக்காது. We cannot document, sir. Once he document, he has not declared, 100% he won't be covered. And the same patient who's been a patient for you for 10 years, he'll come and fight with you for the same insurance. Sir, நீங்கள் சொன்னதுனால நான் எங்கே சார் சொன்னேன் நான் சிகரெட் பிடிச்சேன் அடப்பாவின்னு கேட்டால் கூட சொல்லுவான். ஒன்றும் பண்ண முடியாது. Smoking, they will deny. And the smoking documentation, yes, for our institutional practice, yes, we should. We should, and that is not, actually not documenting is denying our demographic data.
Okay, we should use some cheat words. Yes.
Actually, insurance madam is there. Ma'am should be able to answer it better than I. Smoking is a predisposing factor. If not declared, benefit of. Thank you. I think, sir, madam answered straight from the insurance. Right up. That is their job, sir.
So one more thing I would like to add on, sir, like regarding obesity. So you had highlighted nicely about the obesity as a risk factor, and most of us are obese, and we should accept that. But nowadays, like we have a wonderful drug for obesity in the form of semaglutide. So though it is very expensive, you need to spend around $10,000 per month. But yes, it has a profound weight reducing character, like in the form of 15 to 20%. And that is an excellent thing. That is a groundbreaking. The side effects is very minimal, except for GI side effects. Nausea is the most important side effects. But I think the patient can get away with that. Suppose if they are able to see that their weight is reducing in papers, definitely they'll be able to tolerate it.
Good glycemic control and good weight loss mechanism, madam. Ozempic, highly marketed now, but we are yet to have long years of study on it. Maybe we don't have 10-year trials on it.
Previously used to be injection format. Now we have got the oral formulation, 3 milligram tablet, Ribelsis. That is doing wonders.
3 and 7 milligram of Ribelsis. Wonderful drug. As sir said, obesity has got multiple pharmacological interventions these days, like what we did not have earlier. And these are options which we can use in your patients, which will have good glycemic control and reduction of obesity, and in turn, obviously, all our endorphin damages. Thank you.
For our very enlightening first session. So I would ask Dr. Vishnu Shankar for giving the second part of the talk, continuation of the same topic in terms of primary prevention.
So good afternoon. Thank you.
I request both the panelists and the members to keep your questions crisp because we're running short of time.
So good afternoon. Good afternoon to the esteemed chairpersons here, the respected colleagues and senior faculty members who have been present here. So my talk has been made simpler by the previous speaker, where he has covered most of the risk factors and stuff. Now I'll just move on to the lipid goals, where we should be heading towards in long run for patients who are having either a coronary artery disease or a primary prevention of coronary artery disease, where the lipid level should be. So the introduction was all covered by Dr. Varun Sridhar already. So I'll just go on to the risk factors. This is also covered already. So the risk groups, what I would like to classify is low, moderate, high, very high risk. Either one major ASCVD risk factor, LDL cholesterol levels from 100 to 129, non-HDL cholesterol levels from 130 to 159. Always have a target LDL of 100. So moderate risk is two major ASCVD risk factors, LDL-C of 130 to 159, non-HDL cholesterol levels of 160 to 189, and in this patient also you can still have a patient with target LDL cholesterol levels with 100, but we have to make a big caution here of having the primary disease or the primary risk factor under control. The high risk factor, more than 3 major ASCVD risk factors, LDL cholesterol more than 160 to 189, non-HDL cholesterol of 190 to 219, diabetes with any other major risk factors. This is where the CACS score, the calcium score which Sir talked about, becomes very important. What happens is that there was a parallel study where they compared the calcium score with individual risk factors, and they plotted a graph. A person with even 3 major risk factors of ASCVD will have a very bad prognosis or likely to get a coronary event of patients who are having calcium score with any risk of more than 100 without any risk factors. So for those people, you might have to have a target LDL cholesterol of less than 70 milligrams per deciliter. The very high risk group, diabetes with target organ damage, diabetes with 2 major ASCVD risk factors, calcium score as I told you, try to keep as minimal as possible, less than 50 is ideal. So the risk group, extreme risk group, either category A or category B. ASCVD with more than 1 features of high risk groups, then the calcium score of more than 300, definitely hit hard, go for target LDL cholesterol of less than 50. In case of category B, with same things, with recent or a previous ACS, peripheral arterial disease, try to keep as minimal as possible with the target LDL cholesterol of less than 30. So the low risk groups, normally we try to give them lifestyle intervention, which Sir already talked about how to go about it. Still, we are not able to achieve the targeted cholesterol levels. We might have to think about low intensity statins. Moderate risk groups, to achieve target less than 100 milligrams, we can go up to lifestyle modification, diet, physical activity with moderate intensity statin. If you are not able to follow it up with still, we are not able to reach LDL of less than 100, you can think about a newer drug called ezetimibe. Very high risk group, the target as we always discussed about statin therapy. If its TG is more than 500, go for a fibrate, repeat after 4 weeks and check whether the TG is coming less than 150 milligrams. Then you can add an icosapent, or if the patient is still not able to achieve this kind of goals, you might have to think about adding the newer drugs like bempedoic acid, PCSK9, insulin, whatever has been available in the market and which the patient can afford. So lipid lowering drugs, where are we at this point of time? So I would like to show you the graph of the cholesterol lowering drugs which came from 1955. So from the clofibrate, we have been evolving so much that we are trying to remove cholesterol from the body. But most of the drugs except for BAS or lovastatin, most people tend to have been withdrawn from the market because of the side effects or the complications they were not effective enough. Now, after post-2000, we had this atorvastatin and the rosuvastatin which came up and become a game changer, where every prescription, from the primary point of view, even a secondary point of view, or the patients who have been put in a stent or having a coronary event had been prescribed with statins. Now, from 2000 to 2020, this was all okay, where statins were playing a very important role. But is this the point where we have to think about going far beyond statins? Not only statin is a primary group of drugs. We might have to think about drugs which can always keep the cholesterol levels as low as possible so that they don't get a new event again. Now going on to the drugs proper, statins, we know it's a HMG-CoA reductase inhibitors. They, as we all know, the LDL cholesterol has been expressed for most of the coronary events which has been happening. So we always think about addressing LDL cholesterol and keep it as minimal as possible and achieve that goal, and so that we can prevent most of the future complications. What does statins do? They go and inhibit HMG-CoA reductase inhibitor. So what does it do? They reduce the LDL levels. The available statins which is still preferable in India is atorvastatin. The maximum dose is 80 mg. Rosuvastatin we can go up to 40 mg post coronary events. In primary prevention, the mild dose of statins would be atorvastatin up to 10 to 20 mg, rosuvastatin up to 20 mg. The commonest side effects, GI tolerance and rash is very minimal. Transaminitis or the LFT derangement, which is very common because most of the population we address, the male population, tend to have alcohol history and they have a transaminitis or the rise of LFT. So you without the drug, you can always be reversible with transaminitis. Myopathy, this is one of the rarest complications. Up to 5 to 10% of incidents of patients who are on long-term statins tend to develop myopathy. What happens is that they complain of myalgia, fatigue and all those things, but it's very least incidents. We have been prescribing statins for a very long time and we have not seen many of the patients coming with statin myopathies. Maybe on long run it might be. But is that a warranted need to stop statins? No. Is that something called as statin intolerance? You switch the statin patient to another group of statin. If they are tolerating well, try to increase slowly up to 4 to 6 weeks and see how much they are able to tolerate. If they are still not tolerating, then we might have to brand them as statin intolerant. If they are not tolerating 2 groups of statins, then we can think about going for a non-statin therapy for LDL. But normally, statins are well-tolerated group of drugs and the myopathy is reversible. So, as we said, high intensity for atorvastatin is 40 to 80, moderate intensity is 10 to 20, low intensity is 5. Rosuvastatin 20 to 40, moderate intensity is 5 to 10. Pitavastatin is still in the market for in India, the rest of the statins are not, but pitavastatin 2 to 4 mg is still considered as moderate intensity. We don't go up beyond that. The bile acid secretions, it has been there for a very long time. What they do, they absorb they inhibit the absorption of cholesterol from the gut. So the cholestyramine, cholestyramine, which has been used previously, which has not been used nowadays, so I would like to go ahead of it. The fibrates, this is not preventive in LDL cholesterol, but they do very well in patients with triglycerides and VLDL. So what they do is they go and inhibit the PPAR receptor so that there is no uptake of free fatty acids, and then they reduce the triglycerides levels. This was initially started as a drug to reduce incidence of acute pancreatitis when TGL was more than 500. But then they saw, can they be used as a single group of drug for stroke or a cardiovascular mortality or any other mortality? No, they don't give any benefits. But on combination with any other statins, that's called as mixed dyslipidemia, they provide very good effective role in controlling the future events. Nicotinic acid, the same thing, they inhibit triglyceride synthesis and increases HDL cholesterol, which we don't use nowadays because of the large set of complications which we already have. Now, ezetimibe, the sterol absorption inhibitor, what they do, they inhibit the absorption of cholesterol and polysterols. So, this group of drug is known to cause, the statins are up to reduce 20 to 30% of cholesterol levels, LDL physically, but ezetimibe may be used alone in 15% reduction in cholesterol levels. In combination with bempedoic acid, which is very, very rare, 40% reduction in cholesterol levels. So, these are the group of drugs where does the fibrate work, where does the statin work, and the ezetimibe. Now, going on to the newer group of drugs which has been there for the past 5 years, the PCSK9 inhibitors. What they do, they remove the LDL receptors from the blood, so that from the liver. So what they do, there is no more further uptake of LDL cholesterol, and there is a lot of LDL clearance. And this is for a group of people who are not able to achieve, even after tolerating high dose of statins, your desired LDL levels are not achieved. You can think about PCSK9 inhibitors. The commonly used drugs are alirocumab and evolocumab, but it is 2 weeks, every 2 weeks, which is very costly. It comes up to 40,000 a month. 40,000 a month a single dose. So, Indian population without insurance-driven population is very difficult to convince them to take these kind of drugs. Now, bempedoic acid, which has been recently coming into the market, what they do is they inhibit the ATP citrate lyase. So, they reduce the cholesterol synthesis and decrease gluconeogenesis. So, this has a very important role in insulin sensitivity, and also what they do is they also help in metabolic syndrome. We always had, we don't have bempedoic acid still, we don't have enough studies to say that this will be used as a first line of drug. They can always be an add-on for statins. And always in patients with heterozygous familial hypercholesterolemia or HoFH, they can always try with statins to achieve the desired cholesterol levels. Now, one more group of drugs which has come in is called as siRNAs or insuliran. What they do is they remove completely the PCSK9 from the blood. So, previously we are talking about destroying the PCSK9 receptors. Now, this comes in, takes out the PCSK9. The initial induction dose is 284 milligrams, and then second dose after 3 months, and you have to take every 6 months. Still this is in phase 3 and rest marketing, so we don't have enough data to say that they don't have any side effects as of now. So, the newer drug which is been still in the phase 2, phase 3 is this LPA, where we are normally looking at LDL as one of the primary risk factors for atherogenicity. There are something called as other lipid things which you have to think about, that is LPA. So, LPA and lipoprotein B, apolipoprotein B has to also be considered for one of the reasons for treating patients who are recurrently having ASCVDs. So, patient would have been primary prevention, you would have been started on a statin, but once they are done with that, they will come back to you. Even after a few years, they have been under good control of sugars, but still they are more prone to get, they have not reached LDL cholesterol of a desired amounts, they still get a new event, either a coronary event or a stroke or something like that. Those people, these trials have been worked on what to be. There's one more drug which is not been used, given here, that's called as oral PCSK9 inhibitors, which has been in phase 3 now. They prove to show they are reducing 60% of LDL cholesterol levels. Though mipomersan, this is a newer drug, this is called as synthetic antisense oligonucleotide. What they do is, they go and prevent the apolipoprotein and then they don't involve the further production of cholesterol. They have been showing very good results in heterozygous familial hypercholesterolemia and homozygous familial hypercholesterolemia. But now, because of the hepatotoxicity, it has not been approved, it's only used in homozygous. So the treatment targets we all discussed about. See, going on to the newer guidelines, the ESC or the American Society of Cardiology stick with only LDL. Now only they are just starting to look at it with non-HDL or apolipoprotein B. Always have the guidelines set in for whatever guideline you have. Low risk of LDL is less than 100, non-HDL is less than 130, ApoB is less than 90. So, but extreme categories, you might have to be as stringent as possible, have the extreme risk category at 50, and apolipoprotein is less than 65. So, going on to the guidelines of secondary prevention, this was a risk stratification as Sarah has already highlighted about. I'll go into the secondary ASCVD prevention. So, this is from the American Society of Cardiology. What do they say is, keep the healthy lifestyle. The patient is not at very high risk. If he's less than 75 years of age, give high intensity statin. Make sure that his LDL is less than 50%. If he is not able to tolerate that, go for moderate intensity statin. If he is on moderate intensity statin, or even after giving high intensity statin, you are not able to achieve the LDL of less than 70, go for ezetimibe. If the age is more than 75 years, moderate to high intensity statin is more than sufficient. If they are still able to tolerate that, you can think about switching up to continuation of high intensity statin. But in case of very high risk group, the initial dosing starts from maximal statins, how much ever they tolerate. If they are not able to get the desired dose within the maximum dose of statin within 4 weeks, we have to think about adding ezetimibe. If still they are not able to get, we have to think about PCSK9 inhibitors. But the biggest challenge is that PCSK9 is still very costly. Normally, most of the people will get a good control with ezetimibe itself. So the same thing with chronic coronary artery disease. What we do is the same thing what we discussed earlier. Most of the things are same. For the European Society guidelines and the American Society guidelines, they don't consider the rest of the diabetes and hypertension as one of the risk factors. They tend to keep the cholesterol levels or LDL levels up to 100. They don't say you have to go with high intensity statins in ESC. But American Society of Cardiology says that even though the patient has been diabetic, you have to always have, once the patient becomes having a risk factor, you always have to keep to LDL levels as minimal as possible. Now going on to the Indian guidelines, what they say, you see a patient with ASCVD, you do a non-fasting or fasting lipid profile, go start rosuvastatin at 20 mg or atorvastatin at 40 mg. Do the repeat profile again after 4 weeks. If you are able to achieve LDL less than 55 and non-HDL less than 85, that's okay. Otherwise, think about starting ezetimibe of 10 mg. Then follow it up after 8 weeks. You are still not able to achieve it. If you are able to achieve it, that's well and good. You can continue the same statin as long as the patient tolerates. If you are not able to achieve that, then increase the dose of statins, go up to rosuvastatin up to 40, go up to atorvastatin up to 80, along with ezetimibe. Repeat the 12 weeks. If you see you are not able to achieve the target goals, then we might have to think about the non-statin therapies like PCSK9 or the newer drugs which is available in the market. So this is one of the very important CSA guidelines for acute coronary syndrome. You see the non-fasting, we normally tend to start with the loading dose where rosuvastatin of 40 mg or atorvastatin of 80 mg is already given with aspirin and clopidogrel. Once that is done, you have a baseline value of cholesterol levels. There is no dictum that you have to take a fasting cholesterol levels of fasting. I mean, for cholesterol, except for triglycerides, you can have the non-fasting levels of LDL, VLDL that is more than significant enough to say whether the patient is having an achievable control, and you can establish the baseline values. So if you are after starting, repeat it after 4 weeks, you think about LDL cholesterols more than 55, add most probably a bempedoic acid, then repeat after 8 weeks, achievable range 55, that's fine, not 55, go for PCSK9 or insulin. So this is for LAI, that was from Cardiology Society of India, but in case of LAI or the Lipid Association of India, the guidelines bit differ. Most of them are similar, only for the fact that if you are able to identify the ASCVD risk, give a better control of the ASCVD and take 4 more weeks to assess, and then decide whether after achieving the ASCVD if you are able to give a good LDL control. If you are not able to do that, then you think about second line or third line group of drugs. So now this is the evolution of drugs which we have been having from statins, daily dose of, then now we are just starting with ezetimibe, fibrates, bempedoic acid. Now we are going into newer PCSK9s where they are alirocumab, evolocumab, either bi-monthly or monthly dose. We are thinking about ASO, as I told you earlier, that's only once weekly. But the research has been going on for insulin, that's only 6 months once. But the newer guidelines from ACC has said that they are thinking about vaccinating people with HoFH or HeFH, that is homozygous familial hypercholesterolemia, so that they have a prolonged control of LDL. But if they are not able to do that, there is something called as gene editing. There is one more point which I have left here, that's called as lipid apheresis. What they do is, in patients with homozygous familial hypercholesterolemia or heterozygous familial hypercholesterolemia, something similar to dialysis. They attach themselves to they put a 2-port wire, then they take out the blood, they have a medium to remove the only cholesterol. They first isolate the RBC, then they have a filter where they remove the cholesterol. Once the cholesterol is removed, they send back the plasma again. And this has been done in America for a lot of patients, but it's even costly. But the incidence of LDL reducing is 80% after a single cycle of lipid apheresis. So now we have discussed about the ideas of what are the drugs available in the market, what are the things we are able to do. But in India, there's big challenges. Statin intolerance I have already discussed. Food-centric problems we have already discussed, because the fat, the preservative dependent, high carbohydrate load, all these things have made it impossible for us to achieve a good cholesterol levels on a long run. The rest of the things is we have to look beyond LDL itself. So go for apolipoprotein B or an LPA to assess when the patient is not, you are on proper follow-up, they are able to follow good diet and also have properly following the medicines without any drug compliance. What we do is we try to assess the other things and then address that, so that you can able to get an LDL control over a long period of time. More than this, as we discussed, the ezetimibe or bempedoic acid is very costly. It's not affordable for an Indian population. It is very still being 25 to 30 rupees per pill. So normal low income or a poor income Indian household is not able to get either bempedoic acid or ezetimibe. But the statins are still available. They are good drugs. Now going on to the TGL levels, another risk factors, as I told you, always measure at fasting, 150 to 192, 199. You can always have CVDs. If you are able to achieve good diet control, give them with diet control. You don't have to add a statin, but increase the LDL levels, increase non-HDL levels. They are at high risk for developing ASCVD. Add statins, as I told you earlier, same thing. But if the TGL is very high, you might have to think about immediately addressing this, because the TGL itself can cause an ASCVD, and always make sure that they are more likely to get a pancreatitis. Be very stringent on their diet. Make sure they lose weight. They have a severe exercise habit. They have to quit alcohol and smoking, and other causes of other risk factors like diabetes, hypertension should be kept in control. The fibrates and omega-3 fatty acids have been showed good results in controlling TGL levels. Now going on, as I told you earlier, lipoprotein A and apolipoprotein B, it's been a very good tool nowadays. Even after you are trying to reach a good control, but the patient is not able to achieve the desired control after a long period of time, you might have to think about LPA or apolipoprotein B. This is my last slide. So this is the summary where you have to hit hard. Even the primary event or secondary event, don't think about it. Keep as minimal as possible the LDL, so that it prevents, it reduces up to 27%, 1 milligram deciliter. So the biggest challenge what we face is that will we be able to give the required dose first? Second thing is that on follow-up, will we be able to maintain the patients with the economical situation what we have on the other group of drugs which I told already. Thank you.
Nice, very elaborative discussion. But at the end of the talk, the people must go with some ideas. The most common problem what we encounter in day-to-day life is people with the triglycerides 600, 1000 and all. But they live a comfortable life. The reason is TGL HDL are less penetrative effect than LDL in the endothelium. LDL is the most powerful lipoprotein in penetrating the intima of the coronary arteries to initiate the development of plaque, atheromatous plaque, whereas triglycerides is the malapump. It has no power in penetrating the intima. So we have seen many times 1000 milligram, I've seen 2000 milligram having no symptoms, happy life. If you see the serum of those patients, it will be like a buttermilk. So most of the time, these are the patients have a familial dyslipidemias. We have 3 types of dyslipidemias: familial, primary, what SR is discussed, and third is called the secondary dyslipidemias, more common in patients with the CKD patient, nephrotic syndrome patients with hypothyroidism and end-stage liver disease. They also may have this sort of dyslipidemias, what we call it secondary dyslipidemias. They are also the risk factors for the coronary artery disease. If the CKD patient develops coronary artery disease, the triggering factor is the secondary dyslipidemias. This is one part of it. And second thing is, as you said rightly, high triglycerides can produce acute pancreatitis. Many times people with alcoholic, if they have epigastric pain, we should not miss pancreatitis due to hypercholesteremia also. Very nice, very elaborate discussion. And people may have few things in their mind. The statins, what we get, atorvastatin and rosuvastatin, which is better for which people? Most of the practitioners have the doubt. What is your explanation of that? Rosuvastatin, atorvastatin.
So the Jupiter trial which was done said that rosuvastatin is beneficial at 40 mg and has been proven to be better than atorvastatin, sir.
So it means the rosuvastatin is more powerful, what you say.
Yes, sir.
A patient with 40 milligram of atorvastatin, the LDL level will be controlled with 10 milligram or 20 milligram of rosuvastatin. Okay. So you say rosuvastatin is more powerful than atorvastatin.
Yes, sir.
That is the reason. And the most safest statin is atorvastatin. Rosuvastatin has got some incidence of nephrotic disease syndromes and severe myalgia is happening for patients. If you take more doses of 20 mg of rosuvastatin, the most common complaint is they come to you with a முடியவே இல்லை சார் என்னால் நடக்கவே முடியல சார் ஒன்றுமே இல்லை you do all dengue profile, you do all investigation, everything will be negative. If you see the patient will be taking rosuvastatin years together, 20 milligram. If you do stop it rosuvastatin, you may come out because these drugs it has no eye. It will act on wherever there is a cholesterol membrane. Every cell has got cholesterol membrane, so it acts on the muscles. Not only your target is block of the coronary arteries, but drug will not know where to act. It will act wherever there is LDL, wherever there is dyslipidemias. So nice presentation. Thank you.
Thank you, sir. Thank you.
So what one next? No, sir. As people are rightly said, when there is a risk factor for people without no evidence of coronary disease, no evidence of coronary disease, but still he has hypertension and diabetes, it is mandatory to take treatment to reduce LDL. LDL is a notorious, it is the most powerful. You need time, again very important point I tell you, you need not have a plaque. Even 30% of plaque with a high LDL of 200 LDL can penetrate and initiate the inflammatory process, triggering the cascade of coronary event. Very important point. So LDL is an enemy for us. Okay. So if somebody has got HDL and LDL of equal limit, this man 0, it means HDL 50, LDL 50, safest person for type B. Thank you, sir. Nice presentation.
So one thing I want to tell, there is no marked difference between atorvastatin and rosuvastatin, especially in reversing the coronary artery disease. So atorvastatin 80 milligram and rosuvastatin 40 milligram both have an equal effect. There are studies where they have done IVUS in patients with coronary artery disease and they showed some regression of atherosclerosis in those patients who are taking this high intensity statin. The problem is whether you have to put a high intensity statin or a low intensity statin. That is very important. So high intensity statin start with atorvastatin of 20 milligram, not 10 milligram, and rosuvastatin of 10 milligram. So you have to start straight away with that dose, and you have to gradually up titrate the a drug based on the lipid profile. So you have to do a lipid profile every 4 to 6 weeks, and you have to state whether you have attained the target. So target, as you all already mentioned, that's a good one. So patients who are having a diabetic with a very high risk, the target is LDL is the, because they have chosen LDL instead of other lipoprotein, because LDL has a direct correlation with atherosclerosis, and most of the trial where there is a LDL reduction, there is a atherosclerosis reduction, as well as the main point is the absence of this or reduction in the cardiovascular endpoints. That is very important. So the LDL has shown in most of the trials there is a reduction in cardiovascular endpoints when you treat the target. So the high risk diabetics patients, the LDL goal is 70. If there is a atherosclerotic coronary artery disease, the LDL goal is 55. In the patients who are having a triple vessel disease, multiple stents, severe coronary artery disease, the LDL goal is 40. So this is the goal you have to achieve. But whatever the method you can achieve, but the targets are very, very important. I have seen a lot of patients, in our patients, they have LDL around 100 to 130, and the doctors say it's okay, your cholesterol is controlled, you don't have any. These patients, they present with myocardial infarction, sudden cardiac death, all coronary events. So you have to gradually uptitrate the drug, and as you already told, you have to add a ZMB. So whenever you are not able to achieve with the maximum tolerated dose of statin, add a STMB. If even with STMB, if the goal is not achieved, you have to add a PCSK9 inhibitor. So these are all available in India. Only thing is the cost. The inclisiran cost is around 1.2 lakhs, but it has benefit. That is, we can give every 2 months or 3 months like that. So whenever we don't achieve these target, the patient definitely will be going to have a coronary artery disease or other complications due to atherosclerosis. For what, madam?
Is it atorvastatin or rosuvastatin?
Rosuvastatin, whatever be the target you are achieving, you have to maintain with that same dose. And you have to do a lipid profile frequently. Whether they are maintaining that target LDL is very important.
One question to the panelists, and probably this will be the last question, I think, for this particular session. Either one of you, Dr. Varun or Dr. Vishnu, can also take this question. See, the very premise that you want to classify somebody as high risk, borderline, intermediate, whatever, is based on a tool. You're going to use an ASVD tool or a Framingham risk score or whatever cooks your goose, whatever used in the UK. Now in India, as these tools have been validated for the South Asian ancestry, it is not. Number two, one of the questions which Sir was saying, non-diabetic, non-hypertensive, marathoner, 40 years old, no family history, normal lipid profile, with something, LDL cholesterol, something around 100. But this guy who's been running for a long time just felt chest tightness one day. And he had a suspicion, he took some ECG, it was normal, but still he was not very happy about it. He was very aggressive, he had a cardiology friend. He underwent a coronary angiogram, and they found severe triple vessel disease for him. And he underwent bypass electively within that week. He wasn't in heart failure, but being a doctor, he had access to care very fast, and they were able to. Is this phenotype very common? I want cardiologists to comment on this as well.
So the lipid goals the Framingham study is mainly a Western-based study. So we don't have any South Asian ancestry in that study, but there are new scores available. The recent score is by the ESC, which has given a score called SCORE, SCORE, which is available. They have included some Asians. It is a global score. So they included so many population in that, and this they have validated in trials also. So main thing, what is the difference between the Westerners and Indians is the lipid goals are more in Westerners. For example, if a goal for an American is LDL is 100 means, for Indian it should be less, that is 70, because we are very much prone for atherosclerosis. Even with the LDL values of Westerners, definitely we are going to have a progression in atherosclerosis. That is why the CSA guidelines also tells us that the lipid goals in Indians should be, especially in South Asians, should be less than that of Westerners. So that is true even for that your body mass index, etc. For example, if it is overweight in 27, for Indians it is 24, like that. So for even a lipid goal should be less than that for Indians compared to that of the Westerners.
Sir, a couple of things. the answer to your question would be, has the patient undergone any other non-LDL lipid profile test in the form of apoprotein A or apoprotein B? No. So probably there lies the answer. In the sense like probably the patient would have had a high apolipoprotein A. That could have been one of the risk factor for severe triple vessel disease. And the difference between the Westerners and Indian population is number one, ourselves in Indian population, the apolipoprotein A levels are slightly higher compared to the Westerners. Apolipoprotein A is a risk factor for coronary artery disease. Number two, the heterozygous variant of familial hypercholesterolemia, again, it is 25%. It is slightly more than that of the Westerners. Westerners have a incidence of 15%, whereas Indians have an incidence of 25%. You won't believe, yesterday I had a patient who had just come for a regular cardiac workup and his lipid profile was done, of which LDL level was 213. Straight away, he fits into the category of heterozygous familial hypercholesterolemia. I don't even have to do a genetic test on him. So he carries a high risk, and similarly, the history that he gave was his grandpa died of MI at age of 49, his father died of MI age of 49 years. He is now 35 years and he has come to me. So this is the reason, this is the answer for your question. And number two, I would like to have a question for you. In case of CKD, in patients with CKD, which statin would you like to prefer?
Atorvastatin.
I would like to know the reasons.
Predominantly liver metabolism for atorvastatin, and rosuvastatin has got renal excretion. But rosuvastatin can also be used in CKD, but with caution. But generally statins in CKD, there are certain issues. Once as the GFR keeps dropping, less than 60, for most patients with GFR less than 60 is a risk enhancing factor. So you are supposed to use a statin, and we prefer to use atorvastatin. In rosuvastatin, as said, when compared to the Western population, if you see the actual trials, CKD trials with statin, there are very few. If you take the larger trials on statin, the proportion of CKD population in the trials were also very small in number. So in randomized controlled trials, you find the muscle-related symptoms were relatively 5 to 10% in the common population and slightly more in the CKD population. But in practice, it is very much more. So we find that people are not able to tolerate statin. I withdraw that. I start with a very low intensity, 5 milligram or 10 milligram, or sometimes then after some time, 2 weeks or 3 weeks down the line, they develop aches and pains all over. Though they have multiple factors which can cause that, withdrawal of that certainly produces good recovery in them. So muscle-related adverse effects is common. The other problem is elderly, 70 years plus. Such CKD, if you start them on statin, cognitive impairment is also something which is commonly seen, especially after 6 months or 10 months. You find that there is a kind of a waning of their memory and slowing motor activity. All these things are also observed with long-term statin therapy in CKD population. Those are all my personal views, but I need to really look at how really the cognitive component as an adverse effect in statin therapy is common or not.
There is a recent study being done on the cognitive effect, and they say that it has not reached a statistical significance. As you said, there were a lot of concerns about it. And one more thing I wanted to ask is, there are concerns in the Jupiter trial wherein in patients who were taking statins, their HbA1c level rose. And sir, do you have any answers to that? Because like you have been, people who are having statin and who are non-diabetic tend to become diabetic or pre-diabetic because of the new onset diabetes.
Personal experience, HbA1c new onset is very less, but definitely the HbA1c level rises there. The same set of drugs, the 6.5, 6.7 HbA1c I would have introduced based on their LDL on a routine screening. I would next visit with not much of change in their lifestyle. I have seen their HbA1c go up by 0.4 to 1. Definitely, combined effect is better. Combined effect is better because the point of controlling my diabetes and my dyslipidemia is for my end organ damage and reduction of coronary vascular. So only controlling my diabetes and leaving the LDL is not going to help me. So I continue. But the least tolerable dose is still I achieve a goal of 70.
Sure.
I reach 70 and with add on with another drug or increased lifestyle modification, I'm still within the goal of my HbA1c. I would still like to continue this.
Thank you, sir.
Statin, yes, increases your A1c, your diabetes control. Whether it induces a new onset diabetes, I'm not really convinced of that, though there are many trials, controversies around it. But using the statins in a diabetic patient to reduce your coronary vascular disease, to reach the goal is definitely yes. Not to withdraw the drug just because your A1c is rising because of statin.
Sure. Thank you, sir.
Thank you, Mr. Chairman. I want to say two things. One is a clinical case. My wife, she had a CVA about 6 years back, and we did a complete study. Then they said 4-vessel disease, coronary, and the surgeon said there is no need for surgery. You take medicine, and she refused to take statin at all. Now 5 years. She not even taken a single tablet of statin because initial thing, all those problems, it didn't. So this is one clinical case. 4-vessel disease, 5 years, no statin at all. Second thing is, there are certain things. I had stable angina about 5 years back. I have not taken statin in spite of my repeated request from a cardiologist. Even aspirin and clopidogrel also rarely, occasionally I take. Now only I started taking. Now 5 years. I have not done any angiogram so far. So my point is, are we doing little more in addressing or advising drug and invasive procedures? And the role of alcohol. No, because
I think anyone can who chooses to pick it
No,
up. This is a question which has been plaguing. Statins, are they really villains or really beneficial drugs?
No,
or are we
I had
pushing it and all
been consuming liquor in the last 50 years.
So 5 years, 10 years risk.
The special captain.
So I think sir would take it first. Anybody who will follow suit then, yeah.
Sir, for your question, so first thing is the most of the trials where statin benefit has been shown, or there is no doubt about the trial because proved with intravascular imaging. So intravascular imaging is a thing where they will insert a small camera into your coronary artery and they will image what is the amount of atherosclerotic plaque you are having. So after giving statin for some time, again they will do the test to find what is the characteristic of the atherosclerotic, not only the volume, what is the characteristic, whether you have a high rich lipid pool or what is the amount of cells, all these things they will see. So these studies are robust studies where there is no doubt, because you are not taking statin and you are not having any progression of disease.
No symptoms.
No symptoms. That doesn't mean that these drugs are not work, because unless we do a coronary angiogram on you and we assess what is the state of your coronaries, we cannot tell that.
Sir, thing is, as in your statement, there is some part is true. Sometimes over-treatment is going on, promoted by many reasons, promoting industrial reasons, research. There is some amount of over-treatment is still there. But I would like to bring out the historical perspective. So the MI or SCAD and all not present now. It is there since human being has developed there. It's ages. It's 20 billion years old problems. Okay, Akbar had a problem, but he lived. Okay, in this situation, I tell one important reason, as you know, U.S. President Eisenhower, 1953 to 61, he was U.S. President. He, while playing golf, he developed chest pain and MI. He was admitted in Washington Military Hospital for 18 days, only heparin and aspirin. 18 days, only heparin and aspirin. There is no IV, no OCT, no IVs, no stenting, nothing. But after that, again he has become president, and he continues. This thing is, point is, the drugs will help. Sometimes nature will also help. That is very important point. Nature. Collaterals will develop. Collaterals, very important point. People time and again asking, I have triple cell disease, no symptoms because of collaterals. Good collaterals will not produce any symptoms. One point. Second point, diabetic people. Third point is no exertion. Only when you drive the car, you know the problems of the car. When you don't drive, you may not know the problems. So when you walk, you have the symptoms. Thank you so much, sir. Nice session. Thank you so much, all the speakers. Nice. elaborate discussion. Thank you. We'll move on to next session.
As for- the common misconception, I mean, I would say conception or myth or whatever you call that is, if you eat fat, you will get fat in the blood vessel and you die of heart disease. Is this right or is this wrong? Is there evidence to this? There is no evidence to that. One, can we get a hands up? Those of you who believe that if you eat high cholesterol, high fat, you will die of heart disease. How many of you believe this?
That has been proved in trials.
So I mean, we'll get a number. There are the reason why I'm trying to say is, eating fat, will it get converted into fat in your coronary arteries or not? Certainly not. So the idea which he was talking about, Eisenhower, his personal physician was Ansel Keys. Ansel Keys was the one who started this cholesterol hypothesis. He started saying that coronary artery disease happened because of fat content in the food, and we are vilifying fat in that sense. So dietary fat doesn't translate automatically into a coronary artery disease. The factors which Varun was enumerating, all those enhancing risk factors, presence of CKD, smoking, obesity, metabolic syndrome, high uric acid, those are the kind of factors which are primarily playing. So there are also epigenetic factors. So in those days when things were very simple, people were blaming the diet straight away. So the dietary hypothesis I asked to be revisited, and I would request all the members to look it up on yourself. There are a lot of data which is coming up. And in the future, we should probably not advise our patients and vilify fat needlessly.
Sir, taking sugar by 1 year to a child, will it cause diabetes?
No.
It's a very common misconception. Most of the parents.
I thank Dr. Vishnu and Dr. Varun. Thanks for a very exciting first session. I think we will move on to the next one. Madam.
I would like to invite the chairpersons of session 2, Dr. V.S. Hariharan, one of our vice president of IMA Tambaram, consultant physician at Gleneagles Global Health City. He is also visiting consultant at Sudar Hospital, H2 Clinic and Nirmal Sai Hospital. I would like to invite Dr. Aravind, senior interventional cardiologist at SRM Global Hospital. Dr. Ragavendra, interventional cardiologist and visiting consultant to many hospitals, including Annayarul Hospital, Bewell, Kosh, Lakshya and Kadir Hospital. Now our chairman AMS will be introducing the speakers of session 2.
I now invite Dr. Ganesh, cardiologist from Annayarul Hospital and a very senior cardiologist, for his talk. Sir, please, he will be talking on revascularization strategies in acute coronary syndrome.
I thank IMA for giving me this opportunity. So I thank IMA for giving me this opportunity. So I will make my talk very short in 15 minutes because we are already running out of time. So I am going to, though the topic is very big, I am going to focus only on revascularization strategies in ACS. ACS is a very huge topic. So my talk will be focusing more on revascularization strategies in ACS. So what is ACS? So ACS is a spectrum of disease. It's not a single one. So it starts from unstable angina to NSTEMI to STEMI. So the patient can present at any of the spectrum. Either they can present with unstable angina or NSTEMI or STEMI, or they can progress from NSTEMI to STEMI or from unstable angina to NSTEMI to STEMI. So this is the slide which shows. So you can see the clinical presentation. The patient may have a chest pain. First, most of the patients with ACS, they have chest pain or equivalent symptoms. Not all the patients have classical chest pains. Some of them may have chest pain like symptoms or equivalent, anginal equivalent also, and they may progress from one of the thing to other. So ACS is divided into two types. One is the ST segment, that is STEMI, the ST segment elevation MI. Another is a NSTEMI, that is the non-ST segment elevation ACS. So how to diagnose? So first thing is the clinical context. So you have to take a proper history and know what are the risk factors the patient is having. And second thing is you have to do a physical examination. You have to assess whether the patient is stable or unstable or a high risk patient. And third thing, first thing you have to do is an ECG. Though ECG, though it is a basic one, we divide this ACS into various parts, first based on the ECG. So ECG has to be taken within 10 minutes of presentation to the hospital or to the clinic. So you take an ECG. So you see the ECG, what are all the findings in the ECG, whether the patient is having a ST elevation or whether the patient is not having a ST elevation, whether is having a ST depression, T inversion, like that. The second thing we have to do is, whenever after seeing the ECG and you divide these two into a STEMI or an NSTEMI, you do a troponin. So troponin is very, very important. You have to do a troponin, that too an high sensitivity troponin. So doing a low sensitivity troponin reduces the sensitivity of your diagnosis. So you have to do a high sensitivity troponin, which is gold standard, and you have to get the results as soon as possible. So based on the results of the troponin, you have to divide the patient into a unstable angina or an NSTEMI or a STEMI. So if the patient is having a ST elevation, we can have a working diagnosis of STEMI. Patient directly goes to the STEMI pathway where we can manage as a STEMI. If the patient is not having an ST elevation, having a ST depression or a T inversion, you do a troponin. If the troponin is elevated, you have to go for an NSTEMI pathway. Or if the patient is not having a troponin elevation, still having a features classical of chest pain, angina thing, you can label as an unstable angina. So what are all the recommendations? So you have to measure the cardiac troponins with an high sensitivity assay immediately after presentation and obtaining the results within 60 minutes. That is very important. There is an algorithm, whether there is a single troponin measurement is enough or we need to do a repeat measurements. The ESC has come with a new guideline, that is it is called as algorithmic approach. You do a troponin first on arrival, then again at 1 hour or at 2 hours. So both are equal. So if you find there is a gradual increase in troponin in any of the value, it is very highly significant. So sometimes we may do a 3rd hour measurement of troponin also. So you have to do, based on this algorithmic, we have to diagnose a myocardial infarction. This is called roll in and roll out pathway. So first thing is patient with suspected NSTEMI. So do a troponin 0 or at 1st hour or at 2 hours. It is very low. Then you can do, patient can go to the roll out pathway. Then we can, the patient is not taken for angiogram, other things. Or if they are having a high elevated troponin between the two values or at the single value, they come into the NSTEMI pathway. So in between type of patients or in the patients who are in rule out pathway, if we suspect an ACS, we have to do a non-invasive testing. There are so much non-invasive testing available. Example, you can do a CT or a myocardial perfusion imaging, or you can do a dobutamine stress echo. All these things are available that you can do. For the patient is having an elevated troponin, the patient could come into the working diagnosis of an NSTEMI ACS. So you all know that NSTEMI is first thing, whatever you do is NSTEMI or STEMI will give a loading dose. So loading dose, then other thing very important is we have to rule out other false causes of troponin elevation. That we have to take the history and we have to examine the patient carefully, and we have to rule out all these things. We can see the patients with sepsis, with profound sepsis, not having any cardiac symptoms. In the ICU, they have a troponin elevation. We diagnose him as a case of non-ST segment elevation. We put him on heparin, they will go for bleeding and other complications. All these things we have to be keep in mind. So patient with myocarditis, patient with shock, sepsis, tachycardias, patient with AF who have been reverted, developed an increase in troponin values. So there are a lot of things we have to think about it, and we have to be very diligent. That is how the clinical examination and history is very, very important. So patients, if you take a troponin, suddenly in those patients they will have a troponin elevation that may not be a obstructive coronary artery disease. That may be other reason. There may be a type 2 myocardial infarction where there will be a mismatch between demand and supply. So we have to now we are talking only about the type 1 infarction. So we have to be very diligent about taking a history and clinical context of the patient and reading the troponin values. So when after that, what we have to do is you have to load the patient. So loading dose of antiplatelets is mandatory, both for STEMI as well as for NSTEMI. So we preferably use a newer antiplatelets in our settings. So we go for a ticagrelor or prasugrel, and previously we were loading with clopidogrel also. Nowadays some of the high bleeding risk patients we go with clopidogrel, but preferably I load with ticagrelor or prasugrel, preferably ticagrelor. So after loading, and patient has to be put in ICU, so where there is a monitoring at least for 24 to 48 hours, where there is a defibrillator facility and other things are available. So patient has to be there, then we can start him on an anticoagulation and other cardiac drugs. So anticoagulation, I am not going into the details of anticoagulation, everybody will be know that we give a heparin or that low molecular weight heparin such as clexane or fondaparinux, like that. So that is the thing for anticoagulation part. And other things we will give the patient is having hypertension with failure, other thing you have to manage that part, or the patient is having atrial fibrillation, all these things you have to manage. Then taking the patient to the cath lab, that is the very important one. When to take a patient with NSTEMI to a cath lab, that we have to do a risk scoring. So what is called as a gray score. Gray score has been a validated score. That is one of the important score for invasive management of NSTEMI patients. So there are so many categories in NSTEMI, that is patients who are stable patients, who are patients who are having a risk, and patients who are having a very high risk. So very high risk, what are the patients is? Patient who comes with a NSTEMI who are having a hemodynamically unstable at presentation. Patient who are having a acute severe heart failure, BP unrecordable, or patient who are in cardiogenic shock, or patient who are having a electrical instability such as a NSVT or a VT or a VF going for a cardiac arrest. Then patient who are having acute heart failure and mechanical complication, and if there is a dynamic changes on the ECG. So for example, the ECG shows a sudden ST depression or a T inversion, suddenly it changes to normal, again it goes to ST depression, T inversion, like that it changes very frequently. This means these patients are at very high risk. So you have to diagnose which patients are very high risk, and these patients has to be taken for a coronary angiogram very early. That is the main thing we have to think about it. So patients who are having these things, very high risk patients, you have to take for an immediate coronary angiogram, because the obstruction is very going on, the flow is very much reduced, patient can go for cardiac arrest and death at any time. So second is the moderate risk patients. So patients who are not having a high risk features, and patients who are having a gray risk score of more than 140, and patients having subsided chest pain, not that much issues, they can be taken for an early invasive coronary angiogram, that is within less than 24 hours. So this is the early invasive method. And the third one is patient who are having a stabilized patient. Patient may come with your OPD with chest pain. After treating the patient become asymptomatic, is hemodynamically stable, no electrical features, so everything is stable. So those patients you can wait. So up to 72 hours you can wait and you can take for an coronary angiogram. So very high risk patient, they have to be taken immediately for the lab, and the patients who are having a moderate risk, you can to be taken but within 20 hours. And patients who are stable, they can be managed medically up to 72 hours. Within the time frame, we can take him to lab for further revascularization. This is about the NSTEMI ACS. So another thing is the intra-hospital patient transfer. So that is also very much important. The patient is admitted to a non-PCI capable hospital where there is no facilities for a cardiac catheterization. The patient can be managed initially with antiplatelets, anticoagulants and other drugs, and they have to be, if they have any of the high risk features, they have to be transported immediately to the center which is having a PCI capable center. That is where there is a cath lab is available and a cardiologist available to perform a PCI. So loading, I already told you, these are the drugs. Usually we will load with aspirin 150 to 300. If the patient is not able to take orally, you can give IV aspirin also. And P2 Y12 inhibitors, previously we used to with clopidogrel 300 to 600. I used to load with 600. And the patients, especially in high bleeding risk patients, it's preferable to go with clopidogrel. And other drugs are prasugrel, and other is the tecagrelor. So preferably nowadays most of the cardiologists preferably use this tecagrelor instead of clopidogrel. And if you are not able to load the patient with any of the drugs, or patient is having vomiting and other features, still we are taking the patient for an emergency PCI to the cath lab, we can give IV cangrelor. So revascularization in NSTEMI AC is a very time intense process. So time is very much essential. So patient who, I already told you, patient who presents with cardiogenic shock, refractory angina, hemodynamic or electrical instability, there is no point in waiting the patient, managing in a CCU. Immediately after loading the patient and giving a heparin or like that, take the patient immediately to the cath lab, do an angiogram to find what is going on. Second is patient at high risk, especially if Gray score of more than 40 of clinical events, you can take within 24 hours, and a stabilized patients can wait up to 72 hours. So this is the same slide which I got. Good. So you risk stratify the patients on admission. So whichever category he is fitting. Some of the patient may present with a low category or intermediate risk, they can move to the high risk category. So in those times you should not wait for the thing, you have to take the patient for a cath lab immediately. This is about NSTEMI. What is the type of revascularization? What about PCI? What about CABG? My subsequent speaker is going to talk about the PCI versus CABG. I am not going into these details. So coming to the STEMI, the second part of ACS is STEMI. So what is the, so whenever you had a working diagnosis of STEMI, STEMI is an emergency. So first thing we have to do, see, after diagnosing the STEMI, the patient has come into the STEMI pathway. There should not be any time delay in the transport of the patient or managing the patient like that in a center where there is no cardiologist, nobody to take care. So patient, if the patient presents to a non-PCI hospital, there is a center which has an ICU facility, then they have to give an two things has to be bear in mind. One is whether the patient can be transported to the PCI capable hospital within 30 minutes. If it is right now, for example, the patient is having a MI in a Mudichure, or the hospital is nearby, example Annairul, we can transfer the patient immediately within 30 minutes. It is better to transfer the patient than wasting time in the patient in the pressure near periphery hospital. that will save his muscle. So time is muscle in MI, STEMI. So we have to take care of the time is very important. If you are able to transfer the patient, you transfer the patient to a PCI capable hospital if it is nearby within 30 minutes as early as. If you are not able to transfer the patient within 30 minutes because of various time delays, either in emergency or in traffic or the hospital is very far, all these things, you have to go for an fibrinolysis. So these are the things we have to take the mind, the patient present to a hospital which is not PCI capable. If the patient comes to the hospital, PCI capable hospital, then we have to straight away take the patient for an primary PCI. So other thing is we can bypass the ED also nowadays. So once the patient is coming, the ambulance patient has been informed that patient is coming, we can make the cath lab very fast. We can call the technician, the nurses, everything. Everyone can assemble as early as possible, and the patient can bypass the ED, can go straightly to the cath lab. You have to do a cardiologist should see the patient before taking the patient for PCI, for doing an echo. If there is no technician as available, you have to do an echo, just a quick physical examination, talk to the attenders regarding this. Then the patient has to be taken for a primary PCI as early as possible. So time is muscle, so we have to maintain the time zones. So the patient arrival at the hospital and wire crossing should be, aim is to be less than 60 minutes. So we have to cross the wire within 60 minutes. So wire crossing is very essential. Previously we have door to balloon time, other thing. It has changed nowadays to door to wire crossing. Our patient presenting to the hospital to wire crossing should be less than 60 minutes. That we have to maintain. Then if the patient present to a PCI non-capable hospital, yeah, if there is a they can transfer within 30 minutes. Okay, if they are not able to transfer, do a fibrinolysis, then transfer the patient. So other point regarding fibrinolysis is, so what is the fibrinolytic agents we use? That is a question. So first thing, whenever you are going to take the patient to a PCI, preferably use a tenecteplase. Don't use streptokinase, because the half-life of tenecteplase is very short, that is around 90 minutes. So if you give a tenecteplase, we can take the patient to the lab and we can do a vascular puncture after 2 hours. So after 2 hours we can do a vascular puncture, there is no contraindication. So if you give a streptokinase, means it has to be in the blood for a very long time, and we cannot do a puncture within 2 hours or 3 hours like that. It may cause bleeding complications, especially when you do a femoral puncture and other things. So better to do an tenecteplase, so patient is affordable. And after giving the lytic, don't wait for so much time, for 1.5 hours, 2 hours, so until whether the patient is improving or what are the signs is developed, especially in anterior MI, because once you give a tenecteplase, you open up the artery. When the patient becomes chest pain free, try to transfer the patient as early as possible to a PCI center. That will be a beneficial, and we can do an angiogram. Nowadays, after giving tenecteplase, we can do an angiogram after 2 to 3 hours. That is, we can do. So that is not a contraindication. Giving a lytic agent is not a contraindication for doing a vascular puncture. So that is the main thing. So if tenecteplase is not affordable, or the patient is not affordable, or tenecteplase is not available, go with a streptokinase. So in clinical practice, we see that streptokinase works very well compared to tenecteplase, but most of the studies and other things, they tell that tenecteplase achieve a TIMI3 flow in 80% of the patients. So recommendation for a reperfusion is, so working diagnosis is very important. So if there is a STEMI, symptom of ischemia, so when to do and PCI, so the giving an thrombolytics as well as doing a PCI should be done when the patient present within 12 hours. So up to 12 hours, it's you can do, if they are present very early, it is very better, and up to 12 hours, it's a preferable time where when you give a PCI is very much useful. Thrombolysis, early you give, early you have a better result. As time goes on, when the thrombus become thick and cheesy, it won't open up with your lytic agents. and preferably PCA will be very better in those patients. Second thing is PPCE strategy is recommended over fibrinolysis if the anticipated time from diagnosis to PCA is less than 120 minutes. If timely PCA cannot be performed in patient with a working diagnosis of STEMI, fibrinolytic therapy is recommended within 12 hours of symptom onset in patient without contraindications. So contraindications, other things, I think I am not going into this thing. Rescue PCA is recommended for failed fibrinolytic. That is ST segment resolution less than 50% within 60 to 90 minutes of fibrinolytic administration, or in the presence of hemodynamic or electrical instability, worsening ischemia, or persistent chest pain. So these are all the recommendations for PCE. So what about delayed presentations? Some of the, in India, most of the patients, they present very late, outside the time limit for doing a PCA. They present after 1 day, 2 days, 3 days, like that. So what about those patients who are present after 12 hours? If the patients presents after 12 hours, if the patients have any ongoing symptoms suggestive of ischemia, such as hemodynamic instability or a life-threatening arrhythmias, still we can take the patients for a PCA even after 12 hours. The patient continues to have chest pain, hemodynamically unstable, throwing arrhythmias, heart failure, all those patients can be taken for an PCA even after 12 hours. And after 48 hours, there is no point in doing a PCA because most of the muscle will be dead. That is, in OAT trial, they have clearly demonstrated that after 48 hours, there is no point in doing a PCA. You have to do only the manage the patient heart failure, give drugs and other things. And we cannot do, and most of the time the myocardium will be gone, they become dead or necrosed myocardium, like that. So after 12 hours also we can do, up to 48 hours still we can do an PCE. After 48 hours is not advisable. So this is about transfer. Transfer to the PCA capable center is recommended in all patients immediately after fibrinolysis. Emergency as angiography and PCA of the IRA is indicated, that is infarct related activity is indicated. It is recommended in patients with new onset or persistent heart failure shock after fibrinolysis. Angiography of the PC of IRA, if indicated, is recommended between 2 and 24 hours after successful fibrinolysis. And regarding NSTEMI, I already told you. So what about anticoagulation after fibrinolysis? So all the patients with the tenecteplase, you have to give Clexane invariably, because tenecteplase has a very short half-life. If you don't give a heparin or Clexane after a tenecteplase, the patient after 2 hours will go for reocclusion. So that's why most of the protocols they mentioned either during or after tenecteplase, you have to give a heparin or low molecular heparin. Even for streptokinase, usually we give after 6 hours, like that, because after some of the effects have gone. But on those patients with streptokinase also, they need a heparin. But the streptokinase will have a prolonged half-life up to 24 hours. So they can give after some time. But for tenecteplase, you have to give it immediately. That is after administration. This is a trial called OASIS trial, where they give a fondaparinux for streptokinase patients. And they give a loading dose of 2.5 IV followed by a 2.5 subcutaneous after 24 hours. And they found that the patency is very much preserved in those patients. So what about cardiogenic shock? So other category is most of the patients they present with cardiogenic shock. So cardiogenic shock, patient presenting with cardiogenic shock, don't go for fibrinolysis as the first method of treatment. So immediately you take the patient to a cath lab. So I see a lot of patients with cardiogenic shock, they waste time in the peripheral center and they get very late, like that. So if the patient in cardiogenic shock, immediately you shift the patient to a center where there is a PCA is available. And you have to open the infarct related artery. That is the very key in a patient with a cardiogenic shock. So either you have to, the patient is having acute heart failure, BP is very low, you have to put a mechanical circulatory support. For example, if you have a IABP machine, you can put a IABP, take the patient to the lab, open the infarct related artery. That is the best treatment we can give for a cardiogenic shock. So that is the thing we have to do. And even the patient who are having a type A and type B cardiogenic shock also has to be shifted to PCI capable center for opening of the IRA. And sometimes if you are not able to open up the IRA of the patient is having a severe left main, like that, you have to take the patient for an emergency CABG also if the surgeon is willing. So in the case of hemodynamic instability, so other things I can leave it. Fibrinolysis should be considered for STEMI patient presenting with cardiac. The PPCA is not available. That is, there is a very class 2A indications. That is a previous indication. Because nowadays the cath lab is available everywhere. We can shift the patient as early as possible. If they are in a very far away place where there is no lab available, it is very difficult to shift the patient. You give a thrombolytic agent. So this is the thing. What about the multivessel disease patients? So a patient presenting with a STEMI patient can present with multivessel disease. They may have a culprit and they may also have stenosis at other vessels also. In those patients, the patient present with cardiogenic shock, we will open up the IRA, do a stage procedure for other things. Don't do a multivessel PCA in a patient who presents with cardiogenic shock because it increases the mortality. Second thing, in a STEMI, you do the patient is able, the lesions are very simple and the patients are a stable patient, we can attempt other vessel PCA also at the same time. We can do a complete revascularization. If it's going to be a complex procedure like a calcified vessel or a bifurcation lesion, or the patient is unstable, or he is having a mildly elevated creatinine, other thing, we will do a culprit vessel PCA at the time of presentation. We will do a staged procedure within 45 days. And usually we, some of the hospitals, they do within, between discharge also. Before discharge, they will do a second PC. And in STEMI, I already told you, do a complete revascularization. This is about multi-vessel PCI. This is the spectrum I already told you. This slide presents all these things, what I have told you. Think about ACS, invasive management, antithrombotic, revascularization, secondary prevention. This is take-home message. Early identification of ACS is important. Triage of the patient based on ECG and troponin are key. Prompt referral to a PCA capable center is essential, and timely intervention in an ACS patient saves life. Thank you.
Any questions from the floor?
The PCI and cardiogenic shock, all over the world, there must be a good number of studies. The patient is in shock actually. So how high is the mortality in such cases when you take them up for PCI? What is the mortality statistics?
So if we don't do PCI, mortality is very high, sir. Because cardiogenic shock itself has a mortality of 50%, 40 to 50% is the mortality. So cardiogenic shock has 4 stages. So stage A, stage B, stage C and stage D. And depending upon which stage the patient is presenting to the hospital is very important. Patients who are having a stage A shock, that is the starting of this shock, just they don't have a profound shock, the prognosis is very good. Because they do very well, they don't have that much difference in mortality. Stage B shock, that is patient who are having a stage B, that is the blood pressure crashes on 1 inotropes, and they are able to maintain on 1 inotropes, having good urine output, lactate is not that much high. These are the patients who are having a stage B shock. In these patients, if you take for them for a PCA as early as possible, the prognosis is also good in those patients. Stage C, that is the patients who are having 2 or 3 inotropes, having a lactate of more than 2 but less than 5, going for a decreased urine output, all these things, and they have to be taken for a PCI, but they need a mechanical circulatory support. Because in those patients, if you have a mechanical circulatory support before a PCI, the outcome is good. But if we take them without a mechanical circulatory support, because the mortality is quite high. And the stage D shock, D is very, very worst, and even without treatment they die most of the time. Sometimes we can do a PCI with a mechanical circulatory support. There is a very high mortality. Sometimes the patient can come out or sometimes patient cannot come out. Depending upon the mechanical circulatory support that is available in your hospital dictates the treatment. Because ideally in Western countries they don't, nowadays they use this IABP and other things. They straight away put a impella, which is the thing, and they will take the patient for NPC. In India that's not possible because impella itself costs around 15 to 20 lakhs. So we put a IABP and other things, but IABP don't give that much support in a stage C or stage D shock. But we can, if we are having a IABP in our cath lab, we can put an IABP, we can take the patient for APC. And if we don't do anyway, stage D will have a worst prognosis. Most of the patients, they die. They do go for multi-organ dysfunction and they die.
One more thing I can add, no, please. So the cardiogenic shock, you asked, no, the clinical scenario is more important. If the shock is due to left main occlusion, the coronary artery has got left main. If the left main has got occluded thrombotic event, then whatever you do, the chance of survival is very poor. So because there's no time, sir. The chest pain, global ST depression or ST elevation, external ST elevation, hypotension, if you do echo, hypokinetic, no contraction at all. Most probably they are all left main problems. They won't survive. Whatever you do, they will die. Okay, that's one point. Second point is mechanical complications are very important. Some MIs are present with the VSR, some MI present acute MR. They also, with current shock, they will not do well. So that is a few things I want to add.
I asked this question was, we are now seeing a lot of problems because of violence against doctors and all that. So,
that is a communication problem, sir.
பண்ணாலும் பிரச்சனை பண்ணாம இருந்தாலும் பிரச்சனை ரெண்டு விதத்திலும் பிரச்சனை இருக்குது அதனால நாம பண்ணணுமா where we are really not being supported either by the government or by the legal fraternity. Should we really do it in our country?
That way we say it's only a 50-50 chance.
Patient will die. What I am saying is, you as cardiologist, you are at the receiving end of most of the criticism and all that. If you do, you are damned. If you don't do, then also you are damned. So should you do it in our country? Is the country prepared for this?
That is based on the attenders, sir.
No, that is what. Is this country prepared for this?
If it is well educated, somewhat educated.
No, this country is not prepared for this.
Another thing is electrical storms, sir. Electrical storms, whatever you do, patient survival is very difficult. Electrical storm. Refractory VTVF, very problematic. And for the benefit of the practitioners, the chest pain, normal ECG, people will confused. One simple thing, if the patient points out the finger, pain here, it's non-cardiac. That is one thing. If the cardiac pain, then you can't locate. Very clue. Okay. Second thing is, most of the patients, they come left shoulder pain, no? If there is pain is associated with movements of the joint or any tenderness, it's a periarthritis or bursitis, tendinitis, non-cardiac. This is a point for the practice person.
ECMO is only a temporary, madam. We cannot keep the patient on long term for ECMO. So if the patient comes to a shock, either you can use an impella or an ECMO, or sometimes use IABP with ECMO, impella with ECMO. You can use combination also, depending upon whether it's RV shock or a LV shock or a biventricular shock. All these things are there. The ECMO is only a temporary thing. We have to take the patient for APC, because unless we open up the artery, the shock will not revert. So that's to tide over the crisis. We have to put a mechanical circulatory report. Take the patient to the lab, just to open up the artery. Then the patient, there is a stent myocardium like that, it will improve over the course of time, and the patient will come out of shock. If the patient doesn't come out of shock even after doing a PCI and other things, means the muscle has gone. The patient has to be put on a MCS for a long time, and you have to refer for a cardiac transplantation. That is the thing we have to do.
Thank you, sir.
I have
Koushik, you have a question? Yeah, please.
Sir, with the bombardment of cardiac cath labs that are coming up in lots of peripheral areas and small hospitals, how comfortable would a cardiologist be to do all these rescue procedures without a surgical backup? I just wanted to know that how comfortable you are doing it.
So one thing, this is the SCI has given certain guidelines for doing PCA in patient centers which don't have an cardiac surgery backup. So in this criteria, we cannot do a patients in patients who are having complicated coronary artery disease, it's not advisable without doing a cardiac surgery backup, especially if having a complex PCI, left main bifurcation, and severe calcification. We are using a rota, and all these things are all complicated. That we need a CABG backup is essential. Whether the surgeon comes to our rescue or not, we don't know. But as far as the legal point is concerned, we need to have a cardiac surgery backup. Yeah, I think in most of the time, it's very difficult to have a surgeon during an emergency. That is true. And we have to manage the complication in the lab itself by ourselves. That is only the life saving. Because most of the surgeons, they don't take up those critically ill, or the patient is crashing, the BP is falling, there is a pericardial effusion, patient is not having a pulse. All these things we have to manage by ourselves. And it's very, maybe, I don't know, in Western countries, I don't know, they may have a surgeon on call like that. But in India, I think we have to manage those complications by ourselves in the cath lab. That is the thing. We have a perforation 2 weeks back. We have a type 4 perforation. We managed ourselves in our lab in Hariharan hospital. So even in our hospital also we have 1 or 2 complications. We have to manage by ourselves in our, because very sick patients, they are very sick patients. Even after arranging a surgeon, the cardiac anesthetist, pump technician, and having every OT ready, it takes very lot of time. Until then, the patient won't survive. That is true.
Standby. It has to be there. Otherwise, that center will be declassified.
That is, they have a legal framework. They have a.
But usually, sir, it does not give you time. Patients who end up in complications, they collapse within seconds or minutes.
And they die in the lab.
You don't even have any time at all.
So we have to manage by ourselves.
Yes. Very rarely, vascular complications, CT surgeons can come and help. Some dissections and vascular complications. But once the heart goes in for an asystole, it's nearly impossible for anyone to come and do.
Nobody will
Nobody
help
can help you. Even God can't help you. That is how it is.
There is something called as hybrid lab, wherein like there is a setup wherein during the PCI, if there is some complications, the surgeon can jump in and do the procedure in the same table. So maybe that can save some time. Yeah.
Not be there. Only thing in a surgeon will be of much help in example if you put a device. For example, ASD device or like that we have time to shift the patient to a coronary event. It's impossible. No ways. You have to manage in the cath lab. Cath lab complication has to be managed in cath lab itself.
And one more thing, sir. PCI is not like a 100% successful thing, primary PCI. There are times in which we balloon, the clot burden will be so high that there will be no change at all. At that point, what should we do, sir? I cross the wire, I balloon, thrombosuction, intracoronary tyrafib, whatever we do, 1 in 100 or 1 in 1000, there will be no flow, sir.
So that is the thing. I have not touched that part. Only thing, if you have a huge thrombus burden, the patient comes early. Though the guidelines says that don't do a thrombosuction, I do a thrombosuction in all of my patients, and some of the patients I are able to extract thrombus also. So otherwise you do a balloon, undersized balloon, just you maintain a TIMI 3 flow.
But if there is no flow, sir, TIMI 0 flow in spite of thrombosuction and ballooning, there will 1 in everything, intracoronary sodium. But when the thrombus load is very high, sir, there will not be
that only thing we can do, if you are able to see the thrombus, it is not coming out of your thrombus, because we are using just a 5 French. Don't have that much suction effect. You can give an intracoronary thrombolysis. I have tried in 2 or 3 patients. The thrombus will dissolve. Or otherwise, what I will do, if the patient is having a huge thrombus return, just I put a wire, just a balloon, just I take out all these things, send the patient to a ICU, keep the patient on a GP2B for 2 to 3 days. Again, I will retake the patient after 3 days. That is the dictum I am following. That works for me in some of the cases also. Sometimes, as you said, if there is no flow, even after the prognosis is going to be worse, and they have had 1 or 2 deaths for that patient also.
Can thrombolysis be done after some time? So, if taken for primary PCI, thrombus burden is high. Instead of 2B3A, will tenecteplase or streptokinase be might be more beneficial in those patients, sir?
That we can give intracoronary. Intracoronary you can give. if the thrombus burden say just because there is a new machine called pre-numbera. I have seen one
pulmonary
of the,
embolus.
Pulmonary embolism. They put that sucks very much faster than our thrombosuction. We can, if it is available, we can use those things. But if you are not having these things, either we have to put a balloon, the thrombus load is high, you can give a intracoronary lysis also, just a tenective play small dose.
The problem is, sir, just not a thrombus, it's a thrombotic milieu. The more we remove, the more keeps on forming again and again. And those
patients, we can, only thing we can hope is a deferred stenting. Unless if you put a stent,
gone, sir.
It's
Gone. Stenting is
gone. So these are the areas still under research. As you tell, even the Sky recent document for primary PCI, they tell we don't have 100% efficiency for these things. Still research is going on, new modality of treatment may come.
And anomalous origin arteries and all are headaches, sir.
That is the major
MI in anomalous origin, we might not hook. Old age people, very
80,
tough.
85, taking the patient torch cell, calcified.
If that is not our day, then that is not.
Anyway, time is
I
going
think we'll
on.
move on to the next stop. Koushik, Dr. Koushik,
Dr.
please.
Koushik.
I think we must applaud Koushik for being the last man in.
Good evening, everybody. Thank you for the opportunity to present in the IMA forum. So disclosures, I have none other than saying that I'm a cardiac surgeon. And I would request the people to give me a little bit of levity. I know I'm speaking in a group of cardiologists who are very good practices all around this area, and I please request you to give a little bit of levity for my presentation. It is not done to offend anybody. I'm just going to present what are the concepts of why we do a CABG and what does the evidence and the statistics say. Now my talk is about when to choose CABG, but the more important question before you start a when is a why. Why do you want to choose revascularization? Why do you want to choose PCI, or why you want to choose CABG? Now why is this why important is what we are going to see in the next few slides. Our life and nature has its own ways. Everything in the world is a fractal structure. That is how nature has designed the world. You don't have to, these images are the galaxies, that's the quantum phenomenon. And if you don't have to go that high-fi, if you see a leaf or branching in a tree, this also is a fractal structure. Now what is a fractal structure? A fractal structure is something that is geometrically identical, which can go on branching infinite number of times. So these are fractal structures. They are geometrically identical designs which can go on branching multiple times. So if nature has done this in life, do you think has it done it in the heart? Heart is definitely a fractal structure. The blood vessels of the heart follow the fractal theory. This is how life begins in coronaries. When we start aging, we begin like an open tree fractal structure, and by the time we are 90, 100, our coronaries have become like a mesh, but communicating mesh. So what am I really talking about here? And this is how it branches. In fact, there are theories to state how much a coronary can branch, what will be the length to infinite times using the fractal theory. Now where am I getting with this philosophical stuff? Let's get into the anatomy. Now this is something most of you would be aware of. This is a normal coronary angiogram which shows the left anterior descending artery, left circumflex, and the right coronary artery. This is all that's important. What happens beyond this? Now these are arteries that are visible when the size is greater than 500 microns. That is, the artery should be more than 0.5 millimeters for these to be visible on routine coronary angiography. So what are the vessels that are less than 500 microns? How do they look? So supposedly you go into the middle of the LAD and you want to zoom in and do a speckle image. You will find arterioles like this. These are 100 to 500 microns. And now, do we stop at 100 to 500 microns? No. You go beyond this, zoom it and see. This is less than 100 microns. And probably you can go more than this also. So what are these? How have they classified this? So basically three. Epicardial coronaries, which are greater than 500 microns. There are pre-arteriolar coronaries, which are 100 to 500 microns. These are basically your arterioles, which are less than 100 microns. The point I'm driving home is that coronary artery disease is not an epicardial disease. It's a myocardial mismatch supply-demand. Revascularization is aimed now at only epicardium. So how does the myocardium balance itself? And this decrease in these microns is what drives the coronary flow. If you want to put it in one line, what is the physiology of coronary flow? Epicardium to endocardium, the pressure gradient is the key. This is the only take-home point. The pressure gradient is the key. So Moorthy sir so elaborately explained so nicely about collaterals. So these are macrocollaterals. Like one artery supplying the other is macrocollaterals. They are still important, but my talk will be more on this microcollaterals. I want you all to see picture C and picture B. Picture B, there is no stenosis. I think you can see the 100 micron arterioles that I was talking about. And in picture C, there's a white mark there. I don't have a marker. Can you see that white circle there on the LAD on picture C? That's a lesion there. And then immediately you will see that all the collaterals have increased in their size. All the collaterals have increased in their size. Now, why does this happen? Size of a collateral increases if a lesion causes pressure gradient. There's a normal pressure gradient from epicardial arteries to the myocardial arterioles. And if a lesion is there, this pressure gradient before and after the lesion is going to increase the size of the collaterals. And this is the base of arteriogenesis, which we'll see a little later. And understand that the myocardium has 60 to 70% of the blood volume at any time. The epicardial coronaries are usually non-resistance vessels. So, with this tendency of the collaterals to increase in size once they have a lesion and proliferate in number, and we also know that the myocardium holds most of the blood, there's always this question, why do we need revascularization? Is revascularization needed at all? So the answer to that was done by an experiment. So supposedly, see, these are the two arms of the coronaries. At rest, you get 100 ml of blood. So there's a lesion there. So 50 ml goes in one arm, the 50 ml reaches through the other arm because in the microcirculation, there is dilatation of the collaterals. Am I very clear? Can I have a pointer? So I'll come there. I think I'm audible well enough. So say you have 100 ml of blood coming in both the arms and you have a stenosis in this arm. What does coronaries do? What does collaterals do? They dilate. Once they dilate, the pressure falls here. So you get 50 ml via here and 50 ml via here. This is at rest. Supposedly, you have an hyperemia or say you have exercise. Say your blood requirement is 120 ml. Now 60 ml has to come like this and 60 ml has to come like this, yes? But this is already dilated. The dilation of the coronaries, collaterals on further exercise is limited. So that means you are getting only 85 ml of blood instead of the 120 ml. So this is one of the main reasons why we go ahead with revascularization in the first stage. Because collaterals might limit the infarct size, limit the myocardial death at rest, but not during activity. So next, a little bit about the lesion physiology. We all know that atheromas, plaque, and the plaque ruptures and causes obstruction. This we all know. But where are these plaques located mainly? This is a diagram showing the heart and the coronaries coming out of the aorta from both the ostia. And you will see majority of the plaques are located in the proximal 1/3 of all the arteries. Majority of the plaques are located in the proximal 1/3 of all the arteries. And when does this plaque become significant? If there's a 50% decrease in diameter, it's a 75% decrease in cross-sectional area. The plaques become significant when there is 70% stenosis in the diameter. That means 90% decrease in the cross-sectional area. So above 70%, the plaques are called flow-limiting lesions. Below 70%, it is not so. Now we've seen two things. We've seen that the plaques are in the proximal part, and above 70% is flow-limiting lesions. Now among the various studies that was conducted, begin stating what plaques cause MI actually. It is not the 90% plaques that are rupturing and causing myocardial infarctions. You will see here that less than 50% stenosis plaques, 68% cause them spontaneous myocardial infarction. So it's almost 85% of MI is caused by non-flow limiting lesions. I said the flow limiting lesions are above 70%, but 85% of the MI, myocardial infarction, is caused by non-flow limiting lesions. Now this is where the advantage of CABG first comes. Now PCI is a therapy which aims to revascularize. It treats at the flow limiting lesion. It wants to stent it, correct it. What happens to the remaining plaques that are present in the proximal LAD? Some might be 30%, some might be 20%. What happens to them? In bypass, and you can see there's a distance, the average distance that we put a graft to the LAD or the RCA is 4 or 5 centimeters away from the lesion. We bypass the proximal part of the LAD and give a new channel to the distal LAD. So even in future, if the other plaques rupture, causing a new onset myocardial infarction, the patient is not going to die because we've already given a distal blood flow through the graft. So I just wanted to pose this picture. Is there any truth about focal lesion or just one flow limiting lesion? This is again the same illustration. If you go through that, you can see the stent has been deployed on flow limiting lesions, but there's another lesion there, non-flow limiting lesion, which has a tendency to become a flow limiting lesion in future. And this is where the advantage of CABG really lies. You see the figure there. You have bypassed the left IMA, that is left internal mammary artery, to a distal part of the LAD. Once you have done that, any repeat myocardial infarction that occurs in the entire proximal LAD is taken care of. The patient is not going to have a repeat MI until and unless the graft blocks by itself. Now what is this concept of surgical collateralization? Now I said this collaterals dilate. That's what I said in the starting slides. When there's an ischemia, the collaterals dilate. Now there are two processes in that. One is angiogenesis, the other is arteriogenesis. These are the two fundamental concepts. In arteriogenesis, it is preformed network of arterioles that dilate. That's all. They're already there. Usually they are not in communication in normal heart. Only if a pressure gradient increases because of a lesion, they dilate and communication starts. It is basically mediated by nitric oxide. Angiogenesis is capillary outgrowth due to ischemia. And this takes a little bit of a time to happen. But these are the two main mechanisms by which the heart recovers itself. These are the protective ways of the heart. So this is just to go through what are the difference between it. Its angiogenesis is formation of capillaries, while arteriogenesis is development of collateral vessels. Angiogenesis might take time, takes 3 to 5 weeks for angiogenesis to happen. Arteriogenesis is immediate. I think the rest of the slide I can just go. The main trigger will be nitric oxide. Nitric oxide in VEGF are the main triggers of both angiogenesis and arteriogenesis. All right. So this is called inward remodeling and outward remodeling. Angiogenesis is formation of pre-existing capillaries. So it's inward remodeling. Arteriogenesis is the collateral vessel dilates and starts making new channels. So it's outward remodeling. Now why am I saying so much about this? What does this got to do with CABG? This is an experiment that was done in the pig heart, which the coronary resemble close to ours. So what happens in that is, immediately after bypassing with the Lima LAD graft, you can see the fourth picture. I'm sorry if it's not very clear there. I'm having a clearer picture here. You can see the sprouting of the collaterals. Lima to LAD improves arteriogenesis within 3 days. Within 3 days, it has increased arteriogenesis. Now, why does this happen? Because Lima, that is left internal mammary artery, has an intrinsic capability to release nitric oxide. It is a live graft which is in continuation, which secretes nitric oxide, and nitric oxide, as we see, is the potent stimulator of both angiogenesis and arteriogenesis. This is another advantage of CABG. And we've made enough talks about lima, left internal mammary artery and everything. But what is the most important part is don't look at internal mammary artery as a conduit, but we have to change our perception, look at it like an endocrine gland because of the various secretion that it does. I already told that it secretes nitric oxide, it stimulates the growth of VEGF, it decreases inflammation, it's antioxidant, anti-plaque and anti-proliferative. This is a huge slide, but these are the main effects of lima. So to summarize what we've seen in the physiology and anatomy so far, coronary microcollaterals are far more important than we thought initially. Most of the acute coronary syndrome is caused by non-flow limiting lesions. Coronary artery disease is not a focal disease. It's not even a segmental disease. Survival advantage of CABG is in preventing future myocardial infarction. So it serves as a therapeutic agent and a prophylactic agent. Both are done. CABG stimulates because both angiogenesis and arteriogenesis. And the graphs that we put is an alternate way of the blood to go, commonly referred as surgical collateralization. And we've already seen that lima works as an endocrine organ, not just a conduit. Now, whatever the concepts have been said, they have to be put to practice. What does science say? Science has always been a falsifiable hypothesis. It has to be proven false. So, the era from when balloons started and the first stents came out, there have been thousands and thousands of trials. Every time a new drug comes, there's a new trial. A new stent comes, there's a new trial. There was a point of time when the cardiac surgeon had only trials and no cases. This happened in the early 2010s. And because of the further and further trials, it was just that it was making us a little grumpy. These are trials just for the left main. These are randomized control trials for just the left main. Talking about each and trial, no trial is perfect, and talking about each design of it and outcome of it is beyond the scope of this presentation. But I'll talk about a couple of trials. This is by far the biggest trial that we talk about. Is a landmark trial, Syntax trial. Why it is very important is all the trials randomize patients, choose the patients to randomize, but Syntax was an all-comers trial. And also it gave us something to stratify the coronary arteries. It gave us a scoring system to stratify the coronary arteries, saying that they had different measurements of the coronary arteries, and then you can classify it as low, that is if the score is less than 22, it is low, medium if it is less than 32, that is 22 to 32, and 33 and above is high. So according to this, they followed up a patient for 5 years, and 10 years follow-up has been done and has been published. And these are the graphs. You can see that in a Syntax score of 0 to 22, there's not much of a difference between PCI and CABG. It is not statistically significant. And these are event rates. What I mean by event rates is major adverse cardiac events and cerebral events. That is another death, MI, repeat revascularization or stroke. So in Syntax score of less than 22, not a great difference, not statistically significant. But Syntax score greater than 22, CABG has significant benefits over PCI, and this is the 5-year study. And what about the mortality study? This is a 10-year study where a survival advantage of CABG is noted everywhere. Now, why does a survival advantage of CABG occur? Is because what I said, in prevention of future MIs. I mean, I wouldn't say why surgery won the Syntax trial, but what happened in the Syntax trial? And this is a very important chart. If you look at it, you can see that the non-cardiovascular death was higher in CABG, while lesser in PCI. But I want you to concentrate on this. Myocardial infarction related death. It was close to 30% in patients who had PCI, and it's 4% in patients who had CABG. Now then, because our country there's a lot of diabetics, this freedom trial was done and classified into whether you have to do a PCI or CABG in patients who have diabetes. The trial's 5-year outcomes were published. Death, MI, stroke was much less in CABG group. Myocardial infarction was much less in CABG group. Repeat revascularization was very, very less in the CABG group. This is what the authors or the investigators, principal investigators of the freedom trial has to say. CABG was of significant benefit as compared to PCI. There is no significant interaction among CABG with the syntax score when it comes to diabetes mellitus. CABG surgery is the preferred method of revascularization. This is from Freedom Trial. To put it in a simple analogy, comparing PCI to CABG will be like having an affair and an Indian arranged marriage. The advantage of CABG, like Indian arranged marriage, is only with time and not immediate. Now, what do the guidelines say after this? I don't think I have to go through the slides, and everyone has been going through this. So, the criteria in myocardial revascularization, now when to choose PCI or CABG, calculate the surgical risk, see the complexity of the coronary artery disease with your syntax score or whether it's a left main, and anticipate that completeness of revascularization, which is very, very important in this modern era. You have to revascularize every segment that is ischemic. And the last is presence of diabetes. These are the 4 factors that are considered in the European Society of Cardiology guidelines. Now we divide this into 1 vessel disease, 2 vessel disease, and 3 vessel disease. That's how these guidelines go. So in 1 vessel disease, without proximal LAD, PCI is the preferred method. With proximal LAD, both can be done, but no patient is going to choose CABG for a single vessel disease. Same comes with 2 vessel disease. With proximal LAD, you can do both, but without proximal LAD, PCI is the preferred method. Now what happens in left main, and this was, there are 4 trials for the left main, there was a lot of talk about it. Left main with a low syntax score, the European Society said both can be done, both PCI and CABG can be done. Any left main with a syntax score of greater than 22, you have to give it to CABG, whether it is 22 or 32 or 42, whatever it is. Now, but what did they do? This European guidelines again had a task review meeting in 2022, and they brought down that left main with syntax score of 0 to 22 should also be a 2A recommendation and not a class 1 recommendation. This was done in 2022. So what is the syntax score of 22? When you look at a left main spectrum, in all the studies, why did the Europeans do this? Because all the randomized studies were done on isolated left main patients. But most of them, if you see, left main doesn't present isolated. It is with concomitants with other arteries. And so you'll see that 67% has a double vessel disease or triple vessel disease, and this share directly goes to the CABG arm. There is no question of PCI in this arm. Now what is the type of revascularization in a 3 vessel disease? Now here they change it to diabetes, presence of diabetes or the absence of diabetes. In the presence of diabetes, it is only CABG. PCI might be considered if the syntax score is very low, but it is CABG all the way if diabetes is there. If diabetes is not there and the syntax score is less than 22, in triple vessel disease, if the syntax score is less than 22, then only PCI is indicated. Now talking about diabetes. Now these are European guidelines and American guidelines. They talk about diabetes. And this is a paper from Asian Indians Diabetic Group. So they investigated all these registries, and they said the proportion of CAD patients with diabetes in the Western world is 15 to 20%. In India, it is 30 to 40%. The diabetic load is very, very high. And this paper came out in 2015. Now 10 years down the line, I'm pretty sure this number has also increased. Now, in any patient with a LV ejection fraction that is less, you still prefer CABG. This is just to complete it. I've said it as a 3 vessel. I've left the 1 vessel and 2 vessel disease out of it because most people are going to go for PCI without a proximal LAD stenosis. But if you come to left main and 3 vessel, that is multi-vessel disease, CABG is a class 1 indication in all these patients. PCI can be considered if the syntax score is less than 22. Is that clear? So what are the points that favor CABG? Diabetes favors CABG. If your rejection fraction is less than 35%, favors CABG. If you have a contraindication to dual antiplatelets, if you have a recurrent diffuse in-stent stenosis, and other is anatomical and technical aspects where the syntax score is greater than 33, or PCI thinks that they cannot revascularize all the segments, or a severely calcified coronary artery where you cannot expand the coronary arteries to place your stents. And of course, need of concomitant procedures. If the patient has an aortic stenosis and also has a multivessel disease, there's no question of PCI, it goes for CABG. Now, enough noise has been made in the scientific community. The evidence is very clear. But what's happening? Why is it not translated into real life scenario? If you know that left main and in triple vessel disease, CABG outperforms PCI, you know that. It's evidence based, the survival benefit is there, the concepts are clear. We've all played gully cricket. If the umpire is from your batting team, there is no way the batsman is getting out, isn't it? So aggressive industry drive and marketing strategies, and this is an article published in the American Heart of Cardiology, and this patient had 28 cath lab procedures, placing a total of 67 stents in his coronaries. 28 cath lab procedures with 68 stents. Really begs the question, how much is too much? Now, I am not all against my cardiology colleagues. Like sir presented, Ganesh sir presented, when it comes to an acute coronary syndrome, PCI saves life. There is no question about it. There is no cardiac surgeon who is going to come and operate on you when you are in an acute MI. The cardiology triumphs everybody, whether they are rescuing the patient or bailing the patient. Cardiology triumphs in acute coronary syndrome. But when it comes to multivessel disease or a left main disease or a patient with diabetes, your survival is increased, your need for repeat revascularizations is decreased, everything is done with coronary artery bypass surgery. But unfortunately, like I said, because of the aggressive marketing and the industry driven personalities, we have operated patients. The 10-year survival of the patients is very good, but the average 10-year survival of a cardiac surgeon is very questionable nowadays. Now, every guideline comes up with this. There should be a heart team, the patient should come, there should be a non-interventional cardiologist, an interventional cardiologist, and a heart surgeon. They should all sit and talk and write the syntax score. In India, or in most of the places, this is the heart team. It's I, me, myself. Whoever is the first physician to see, it might be a surgeon or it might be a cardiologist, he is the heart team. There is no cross consultation. The decision is taken then and there. But I hope that the explanation to the patient is not just given in 2 words. CABG, longer stay. PCI, shorter stay. This should not be done, and it's not sufficient for the patient. He should know the concepts of revascularization. He should be told that there is one less invasive strategy where you have earlier recovery. There's a more invasive strategy which will prevent future myocardial infarctions and thus increase your survival also. And that's the education that we need to give the patient before asking a consent from him. Right. So just to summarize a few things, current terminology appears inappropriate because it's just not revascularization, because CABG is both therapeutic and prophylactic. This needs to be explained to the patient. Patient consenting cannot be done by one physician or one surgeon. It has to be a team approach. All the advantages that I said will happen only if the grafts stay patent. Vein grafts, around 25 to 30% block in 5 years' time, and now the surgeons have resorted to multiple arterial grafting, which stay patent for a longer time period. So that is the way we should go. Better stents will probably not lead to better survival. We've had stents coming up for the last 15 years. Every time a stent comes, it's considered the best. And every time they compare it with CABG, and you find advantage with CABG. But before that study comes out, there's a newer stent that's coming. So you go on this vicious cycle of comparing. Medical therapy is complementary to CABG. I didn't put that article up, but post-stenting, the patient's compliance to medication is 53%, which is miserable. Post-CABG, the compliance is 25%. So this is something that we have to look at. Medical therapy is complementary to both CABG and PCI, I would say. And the assessment of CAD, it's not only eyeballing now. There's IVUS, FFR, and various other methods have to come to find the actual ischemic zones. Just for a sense of humor. These are 3 janitors. who are collaborating wonderfully in a very coordinated way, helping each other in ways beyond imagination. If janitors can do this as cardiologists, cardiac surgeons, we can be a more cohesive, collaborative, and coordinated team, putting patient in the center. Thank you.
Panelists, you want to put some questions to him?
There's no right way to go about it actually. This is a discussion which has a no right answer. So what I would like to say is like how our phones 20 years ago we had a big phone, then came the small one, then came the small one. That's how PCI evolved. With every new intervention and new discovery, the mortality rates reduced actually. For calcification, IVL came. Rota was there. After now there is IVL which has less complication, which is very easy to do, which has no skill. That reduces complications. So the ideal way may be, like it depends on the patient. Each and every patient, some patients may not be, physically well, but they may not survive CABG. For those patients, even though PCI may not give you complete revascularization, PCI is beneficial. It's like what they'll say, we won the game, like the patient died, but surgery was successful. That should not be the case. The patient, it should not be like that. There is no clear-cut guideline, even though guidelines are there, practically we have to sit with the patient attender, explain him the pros and cons, and make a right decision as such. But it's not so drastic. Interventions have improved drastically, and the success rate with PCI actually is very high now. The complication rate and death rate is not very much when compared. These studies were done with stents which are of previous generation. Newer generation stents have come, newer antiplatelets have come. The risk of stent thrombosis has reduced drastically with newer drugs. But still, I'm not saying, I'm not against CABG, but for the correct
Can you just have a
candidates.
comment? That's exactly what I was saying. Now, every time a stent comes, the complication has decreased, isn't it?
That is also
we are talking about what is the success rate of PCI? Crossing the lesion and putting, it should not be that. It should be survival. Let me finish. It should be survival when you see in 5 years and 10 years. By the time I do a 5-year study and it says CABG is better, no, sir, now a new stent has come, sir. It is much better than the older stents.
But that's true, sir. In Jipmer, before it started, the stent thrombosis, every week a patient used to come with the bare metal stent. But now the incidence of stent thrombosis is just 1 or 2 per year in more than 5,000 cases in Jipmer. That was how the study was made.
I mean, I'm just, it's not arguing or anything. We are not talking about stent thrombosis. We are talking about the survival advantage that a surgery gives in a multivessel disease.
In a multivessel?
No, just let me finish. I'm not talking about you deploying a stent across a lesion successfully. That is not counted as success of stent. Does the patient outlive if a CABG is performed at the same time? Is the question. The stents, this is not the first stent that you've got. From BMS to DES, first generation, second generation, third generation, everything is there. At least we have 20 randomized trials comparing this. What do 19 trials say? There is a survival advantage in CABG, is all I'm saying. It is not success. I cannot put 3 graphs and say those graphs are all successful, right? That is not the way to go about it.
As such, even patients die on table in CABG, patients die on PCI.
I'll put the end for this, okay?
I think those part of the debates will stay after hours.
Point is, atherosclerosis is not the one-time process. It is a continuous process. You do CABG, is it a guarantee for lifelong? Manmohan Singh had a 2-second CABG. So atherosclerosis is not a single time. It is a lifelong process. You do graft will get occluded. You have seen 3 years after CABG, people come with the graft occlusion. That's one thing. And Indian population will never suffer pain. When the anatomy is suitable, go for stenting. Anatomy is suitable, go for stenting. If the patient is willing for stenting, do the stenting. Nobody is interested in CABG, especially in country like China, South Korea, Taiwan, and South Korea. There is no CABG. Japan, no CABG. They totally, CABG is vanished. Surgeons are vanished from these countries.
I have to make a comment after this,
okay.
If I am.
And because not only for the technology advancement, and they are not interested in opening their chest. They think if they open the chest, the soul will go out and they are not ready for that also. Okay, and
Let me
when you have a treatment available free of pain, free of any, the CABG is not a risk-free procedure. They also develop stroke after the procedure, wound dehiscence are there, diabetic people, women, wound dehiscence are there, wound will never heal. And even after CABG, people have chest pain for 10 years. I have a patient. Chest pain with 10 years, CABG.
Answering your questions one by one, sir. I did not say that atherosclerosis is not a continuous process. We all know atherosclerosis is a continuous process. When you put a graft distally, myocardial infarction caused by atherosclerosis is way lesser in CABG than in PCI. It is proven in all studies. There's no question about it. If anybody says atherosclerosis, nothing. PCI, that atherosclerosis progress is not protected as much as in CABG is the point I'm driving. This is not a talk about where CABG is happening, where PCI is happening, who is doing it, who is not doing it. I've presented the science, the facts. That is all, and the evidence.
And science is good. I agree. Science is good.
Follow the, a book A leads to B, B leads to C or so. So it depends, each one carries his own, but there are certain facts, and I would say even in CKD population, CABG has better outcomes than stents. Because one major reason is most of them are calcified lesions. So a stent doesn't really make a difference there. So you can pick and choose what you want, but overall the evidence has been presented and it has to be individualized, customized based on the availability of resources, what works well, should well. But overall, these debates are essentially to make us understand how complex these decisions are and why it is important that we need to have a hard team.
What about that minimal invasive CABG?
They're not large trials now. What has happened now in most of the American states, they do a hybrid therapy. That is, they put a lima to LAD and leave the right and OMs to stenting. That is what has really taken off. Robotic CABG, the problem is the robot is not used. It's only used for taking IMS. So in minimally invasive CABG, you put a chest retractor and take it with a cautery or a harmonic scalpel. In robotic CABG, you harvest the IMS with the robo. As such, the anastomosis is only minimally invasive. It is not robotically done. Only few cases were totally robotic, but that has not come into practice completely.
So which patient do you choose for minimal invasive?
Minimal invasive at this point of time, single vessel long segment LAD. That's all. I wouldn't do a triple vessel disease in minimal invasive at this stage.
What about RCA?
RCA, better leave it to the cardiologist. You can do it. There are people doing it. You put a lima Y and bring the lima and you can do it to the PDA technically. But you put an arterial graft on a PDA which doesn't have lesion more than 90%, 30% of them occlude within the first year. This is what the study has shown. So I would be skeptical. I'm talking about me. There are people who do triple vessel, 4 vessel with minimal invasive, but I have not done it, and I cannot speak for them.
So one last word. There will be many people for PCI and these things, and very few people for CABG. But I think he's just only trying to make one point. He says where you feel that you people should not do it. Don't do it. That's what he's saying. He's only saying that. He says there are some cases like diabetics or triple vessel disease where putting so many stents is not going to be of much use to the patient. It is better that the surgeon is roped in at that moment, and there should be a healthy discussion between the two. To come to a conclusion. It has to be there. It has to be there. We cannot wish it away.
This is going to be a never-ending debate, both on dais and off dais, in the scientific community as well as outside. What I would like to say, there are nuances on both the sides, both from the PCI aspect, from the surgeon's aspect, CABG aspect. What I would like to say is, it is our moral obligation to present the fact to the patient.
That's all, correct.
And you tell the pros and cons, along with the numbers, and let the patient take a decision on their own.
Whatever you might try to explain to the patient is not that intelligent enough to come to a decision. His decision comes by
I think on that note,
commonsensical thing.
sir.
My chest need not be open. Remember that. So it is upon the scientific community to have a very rational discussion on this and come to a conclusion. I am not pro-surgeon or anti-cardiologist. It's not like that. I'm just saying that we must have a very healthy balance.
Being an interventional cardiologist, even I am not that way. What I want is the patient should get the benefit, whether be it a stenting or be it a CABG.
So I think to some extent we must have a balance where we ourselves clearly say cardiologist triple SLA ரொம்ப expensive you go for CA. That's what he is trying to say.
That is the owner's onus. That is what I was trying to point out.
Sir, I think we will, I mean, it's wonderful, some degree of excitement, last minute adrenaline rush and all that is important. Most people are woken up, I think, now. So, brilliant discussion by all of them. And I would request the panelists from the first and second session, please be available for us. We want to give a small memento for each one of you to commemorate it. Thank you. Thank you for staying so long.
So we move on to the felicitation. I request our North Zone Vice President, Dr. Kasi sir, to felicitate Dr. Moorthy sir. Nanda, photo. May I call upon Karunanidhi sir to felicitate Dr. A.K. Gautham sir. Sir, please. Murugan sir to felicitate Dr. Dhanraj. Dr. Dhanraj is here? No, he has left. Then Murugan sir will be felicitating our chairperson, Dr. V.S. Hariharan. I request Selva Ganapati sir to felicitate Dr. Aravind. Sugumar sir to felicitate Dr. Ragavendra. Sugumar sir to felicitate Dr. Ragavendra. I request the chairpersons for session 1, Dr. Moorthy, Dr. A.K. Gautham and Dr. Dhanraj to come over to the stage and felicitate the speakers of session 1, Dr. Varun and Dr. Vishnu Shankar. Chairpersons of session 1, Dr. Moorthy, Dr. A.K. Gautham to felicitate Dr. Varun Sridhar and Dr. Vishnu Shankar. வடை பத்தலையா நல்ல வேகமாக கைத்தட்டு May I have the chairpersons of session 2, Dr. V.S. Hariharan, Dr. Aravind and Dr. Ragavendra on stage to felicitate Dr. V. Ganesh and Dr. K. Koushik. Thank you very much. That was a very wonderful session. Now I request our Finance Secretary, Dr. Prashanth Pandian, to deliver the vote of thanks.
Thank you everyone. Thank you everyone for the lively session today. It's an honor to be giving the vote of thanks today. I thank my President and Secretary for giving me this opportunity. I thank our Vice President, North Zone Vice President Dr. Kasi sir and senior IME leaders for being here and for your gracious time. It was wonderful to have such good talks over here, and thank you everyone for staying back. I thank the office staff for making this happen, and special thanks to Anayarul Hospital for sponsoring the event, and our AMS chairman Dr. Venkatesh sir for facilitating this. Thank you everyone. We'll call it